Just wait. Your first speaker is here?
Yeah, Kalpana is here. Dr. Kalpana? Yeah, she's
Yeah,
there.
Kalpana.
Yes, ma'am.
Kalpana, have you checked your PPT?
Yeah, I'll do that. I'll do that.
Just check so that we can start. And if
Yeah.
Janvi is not here,
Yes, ma'am. Palnipan sir, can you please stop sharing so that I'll try my.
let her check and then we will start. Yeah. Meantime, you can see, is there any of the chairpersons? Great. We can see Kalpana.
Yes, ma'am.
Just make it slideshow.
Yeah, it's moving, no, ma'am.
Yeah, it is moving.
Thank you. Yeah, I'll just stop sharing so that.
I think you can start and you can only introduce once the chairpersons come in, they can take over, I think.
Yes, yes.
In time, yeah. Yeah, Lakshmi, you can start it.
Yeah. Yes, Palaniappan. Yes.
Good afternoon, ladies and gentlemen. A very warm welcome to the ICOG Masterclass, which has been happening quite well and very successful under the chairmanship of Dr. Lakshmi Shrikande, with the President, Dr. Rishikesh Pai, and Dr. Madhuri Patel, Secretary General of FOXI, and of course with the well-wishers of Dr. Parag, Dr. Ashok, the ICOG office bearers, and with the conveners, Dr. Madhuri Patel and me. And this has been going on very successfully. And today we've gathered here today for another very enthralling session on infections in pregnancy, not always scary. When the pregnancy is infected by some infection, we get very worried and we say, oh, what is going to be the outcome? But then the idea of this masterclass is to educate all of you to say that infections in pregnancy is not always scary. We have definitely rules and roles for combating the infection, and we'll be able to save the mother and the baby very well. And that's the purpose of this masterclass. And we will have 6 small lectures on this, and then a wonderful question answer session interactive with them. And while the chairpersons join in, let me welcome Dr. Lakshmi Shrikande, our chairperson of the ICOG, to address this August gathering and give us her blessings and wishes. Over to you, Dr. Lakshmi.
Thank you. Thank you so much, Professor N. Palaniappan. Friends, this is our second masterclass. First was on PCOS, which was a grand hit. And here the choice of topics and speakers is simply commendable. The convener is Dr. Professor N. Palaniappan. And I am so happy, Professor Palaniappan, that you have chosen 6 common infections. That is malaria, dengue, HIV, UTI, SSI, 5 infections, and then of course the use of antibiotics. As you said, key infections in pregnancy are not always scary, but we being obstetricians and gynecologists, we are always concerned about mother and the baby. So here we have come out with a module to educate, as he has already said, how much we all should be concerned about these infections, how to deal with these infections during pregnancy, and when it comes to the treatment. So what should be the treatment and which antibiotics and the medicines are safer in pregnancy. So with this in mind, ICOG brings to you the second masterclass on infections in pregnancy, not always scary. So without wasting much time, I hand over back to Professor N. Palaniappan for further proceedings.
Thank you, Dr. Lakshmi. And I'm sure Dr. Lakshmi is known to everybody, and she's from Nagpur, and she's hosting the RRR conference in the month of March. And we're all looking forward for that wonderful conference which she's going to host. And I'm sure her CV reads 2 pages, and we'll be discussing Dr. Lakshmi's achievements for the next 1 hour, and the session would not get over even then. And so I'm sure you're able to see her CV there. But what is very enthralling about Dr. Lakshmi is her enthusiasm, which just profusely flows out when she talks to us, and the way she makes us work, and of course the RRR conference, which is going to happen sometime in March, and I'm sure all of us are going to have a wonderful time on the conference in Nagpur. And the chairpersons for the day are Dr. Jem Kannan, who will be joining us soon, Dr. Ashish, and of course Dr. Sheila V. Mane, who are all not people whom need introduction at all, and they're quite well known to all of us in this podium. And the first speaker of the day is none other than Dr. Kalpana. Dr. Kalpana is a gynecologist and infertility consultant, Guru Hospital from Madurai, and she's the National Coordinator for Infertility Committee of FOXY, Course Director for Postdoctoral Fellowship in Endogynecology, affiliated to Dr. MGR Medical University, Chairperson of the Infertility Committee of the TNFOG, which is a new federation formed by the Tamil Nadu, Secretary of the Madurai Obstetric and Egg Society, and I'm sure we all witnessed the wonderful UFOXY conference which he conducted last year, and a couple of us would have been attending the conference. And needless to say, her academic acumen and the enthusiasm with which Dr. Kalpana Balamurugan shows across, and she's been awarded the Best Doctor Award by the MGR Medical University and Golden Excellence Award by the European Continental University and Medical Excellence Award by the Governor of Tamil Nadu, and Best Medical Service Award from Madurai District Collector. And she's going to speak to us on the first topic of the day. And over to you, Dr. Kalpana. Let me stop sharing and welcome to the first topic of the ICOG Masterclass on infections in pregnancy, not always scary.
Thank you, Palniappan sir, for the kind words of introduction. And first of all, I would like to thank Palniappan sir for the wonderful opportunity given to me. And my special thanks to Rishikesh Pai sir, FOXY President, Lakshmi Srikante ma'am, ICOG Chair, Parag Benivale sir, Vice President ICOG, and Madhuri Patel ma'am, Secretary General FOXY, and also Secretary ICOG Ashok Kumar sir, and other convener Madhuri Patel ma'am for this wonderful opportunity. Malaria in pregnancy is the topic for discussion today. As far as adults are concerned, malaria, severe malarial infection is rare nowadays because of repeated infection. But in pregnancy, again, severe malarial infection can happen, probably because of altered immunity, and also probably because of new organ, placenta, which can bind to malarial parasites. So malarial infection in pregnancy can adversely affect the mother and also the fetus in the form of anemia, low birth weight, stillbirth, IUGR, and whatnot. So now let us see the literature evidence of malarial infection in pregnancy. When we look into the malarial species, when we vivax, ovale, and also malaria, the most common species is Plasmodium falciparum, which is almost 75% of malarial infection is caused by falciparum. We are worried about malaria falciparum infection because it is associated with a mortality of almost 1%. Many a times we encounter uncomplicated malarial infection where the patient has got a parasitic load which is infecting almost less than 2% of our disease. So these patients are mostly asymptomatic with no signs and symptoms of severity. So many a times we encounter patients with typical symptoms of fever, sweats, chills, sometimes headache. Sometimes the patient do come to us with GIT symptoms like nausea, vomiting, diarrhea, and sometimes with cough also. Always look for anemia, jaundice, splenomegaly in these patients. Sometimes the patients do come to us with severe malarial infection, which is quite Plasmodium falciparum, because Plasmodium falciparum tends to increase the stickiness of RBCs to the blood vessels, which can form thrombus in the microvasculature. Ultimately, in over a time, it may cause organ failure, especially renal failure, and sometimes related to central nervous system. Placental sequestration has also been documented in many patients, but it is not quite common in vivax, ovale, and malaria. So in patients with severe Plasmodium falciparum infection, the patient may present to us with hemoglobinuria, jaundice, sometimes profuse bleeding because of DIC, sometimes related to organ failure, especially renal failure. Sometimes thrombus in the central nervous system can present as convulsion or altered consciousness. Pulmonary embolism is also quite common. So pulmonary edema, acute respiratory distress syndrome can be a presenting symptom in those patients. So when we encounter those patients, always look for severe anemia in the form of hemoglobin and platelet count, and also look for the complications related to the presentation, especially renal function test. Puncture if the patient is presenting with CNS symptoms to rule out meningitis. These patients can have metabolic complications in the form of hypoglycemia, acidosis. So look for all these complications when a patient is presenting to us with severe manifestation. So maternal complications may be anemia, fetal complications, miscarriage, low birth weight, preterm labor, and stillbirth. As we've already discussed, Plasmodium falciparum has got a greater morbidity and mortality of almost 1%, but always remember that Plasmodium vivax is not as benign as we thought previously. How are we going to diagnose these conditions? Many a times the patients are asymptomatic or sometimes with mild flu-like symptoms, sometimes with pyrexia of unknown origin. Always ask for the history of travel to the endemic area, and microscopic diagnosis is really essential because species identification is really essential to plan our treatment with anti-malarial drugs depending upon the species we identify. So rapid detection kits are available, but it is not very popular because it may miss low parasitemia, which is quite common in pregnancy also. Sometimes the sensitivity to identify the Plasmodium vivax is really low. So, when a febrile patient comes to us to rule out malaria, repeated smear is really needed, and 3 negative smear 24 hours apart confirms that she is not having malarial infection. Sometimes false negative smear is also possible, especially when a patient is on prophylaxis or if a patient comes to us from an endemic area where the immunity is really high. So the smear will be negative, but the placental sequestration will be positive in those patients. So to diagnose, more than 5% of leukocytes usually have malarial pigments. So moving on to the management, as we all know that chloroquine is the safest one. It can be given at any point of time. It is quite suitable for patients who are infected with vivax, ovale, and malaria. But if the patient is infected with the falciparum, if she is uncomplicated patient, the other alternative can be quinine plus clindamycin. But if a patient is presenting with severe symptoms, IV artesunate may be the first choice of drug. Other alternative drug is IV quinine. So if a patient is presenting to us with severe infection, always it's teamwork. We need obstetrician, neonatologist, infectious disease specialist and intensivist to treat the patient. So always look for anemia, thrombocytopenia, metabolic complications, and the related to symptoms. We need to investigate her further to find out other complications. Always remember, whenever we are giving quinine as an anti-malarial drug, the patient may have headache, tinnitus, nausea, and diarrhea, which is a side effect of quinine, which may overlap with the symptoms of malaria. So as we have already discussed, non-falciparum malaria is not very severe and the patients can be treated as OPD basis, but falciparum malaria infection needs admission and severe monitoring. Always remember that when we are giving anti-malarial drugs to your pregnant patients, it is less effective than non-pregnant patients because of lower concentration. So always monitor for recurrence, which is quite common in these patients. So coming to the dosage of different drugs, as we have discussed, Plasmodium vivax, ovale, and malaria can be treated with chloroquine, which is usually given in a dose of 600 milligrams, 68 hours later, 300 milligrams. And then on day 2, again repeat 300 milligram dose, and day 3 again 300 milligram. So this is a very safe drug, can be given at any point of time, but if the patient's presentation is with falciparum, it is always better to go for a higher drug, which is oral quinine, which is given 600 milligram TID dose in association with clindamycin, which is 450 milligram TID dose. But if a patient is presenting to us with severe complicated malaria, the ideal drug would be artesunate, which is given 2 milligram per kg IV. And if the patient is recovering very slowly, orals can be started at that time. Oral artesunate at a dose of 2 milligram per kg can be given to these patients. Alternative regimen is quinine, which is given in a loading dose of 20 milligram per kg, and then gradually it is maintained at 10 milligram per kg TID dose, and then it can be shifted to oral medication also. Many times the patients do come to us with recurrence. The recurrence rate with quinine is almost 75%, because if the patient is on hydroxychloroquine, then for recurrence, the patient can be treated with quinine. If the primary drug is quinine, if the patient is coming to us with recurrence, the next alternative is artesunate, which can be given IV. WHO also recommends for recurrence, artesunate can be given 2 milligram per kg per day or 100 milligram daily for 7 days in association with clindamycin 450 milligram TID for 7 days. Always when a patient is coming to us with severe malarial infection, in addition to anti-malarial drugs, we need to concentrate on the severity of the symptoms. If the patient is coming to us with convulsions, coma, with in association with neurologist, the patient has to be treated. Hypoglycemia is a quite common metabolic problem we encounter for these patients. If it is less than 40 milligram infusion of glucose containing fluid is really necessary, and severe anemia should be treated with Paxil, and sometimes the patient may present to us with respiratory distress. Think about pulmonary edema and look for JVP and central venous pressure. If it is less than 10, it rules out pulmonary edema. But at the same time, if it is a diagnosis of pulmonary edema, treat the patient with diuretics and also restrict IV fluids for these patients. Renal failure, again, in association with nephrologist, intensivist, the patient should be treated because it's a life-threatening condition. Spontaneous bleeding because of de-icing is also quite common in these patients. So treat with whole blood cryoprecipitate, FFP, and platelets if possible. So whenever the patient presents to us with shock, always think about secondary bacterial infection and treat with antibiotics also. So when a patient with severe malaria complicated by fetal compromise, a multidisciplinary team approach of intensivist, infectious disease specialist, obstetrician, and neonatologist is really needed. Congenital malaria is quite common when the patient is having severe malarial infection in the peripartum period. It is actually passage of parasites or infected RBC from mother, but not by the bite. So you always suspect congenital malaria in a patient with peripartum malaria, and always go for placental histology and blood films from baby and cord is really needed to confirm congenital malaria. So if the patient has got a positive blood smear and the baby is presenting with fever, it could be congenital malaria, and the baby should also be treated with that. To conclude, severe infection is also quite common in pregnancy because of alteration in the immunity status and also formation of new organ placenta, which can cause sequestration of the parasites. So anti-malarials should be started immediately when you think about congenital malaria when the patient has got peripartum malaria. Thank you so much for the opportunity. Conclusion slide.
Thank you very much, Dr. Kalpana. That was quite an illustrative lecture on malaria in pregnancy, and we will take the questions at the end. I request you to be logged in till then, and meanwhile we will have the, can you stop sharing, Dr. Kalpana? Yes. So meanwhile, I'm sure our two chairpersons have already logged in, Dr. Jayam Kannan and Dr. Yeah, Dr. Ashish has also joined in. So let me welcome Dr. Ashish, Dr. Jayam Kannan, and of course, Dr. Sheila Mane, our three chairpersons who have just joined in. And here are we with Dr. Jayam Kannan. Dr. Jayam Kannan was the Vice President, FOXI 2018, and President, Member, Post Director, PMNCH WHO since 2008, Certificate Course in Reproductive Medicine, FOXI since 2012, and she's got so many achievements to her credit, and she's been instrumental in bringing the Trichy Society to the central FOXI focus. And so when we think in terms of Trichy Society, we always think in terms of Dr. Jayam, and she's lead assessor with exceptional commitment to the Manyata, and she's got the RCOG Award and Distinguished Service Medal 2018, first Indian to receive. And welcome, Jayam Madam, for this wonderful session, and thank you for sparing time, though you had initial connection problems. I'm very happy to have you here, Dr. Jayam. The next chairperson is Dr. Ashish Kumar Mukhopadhyay, who is a principal and professor, unit chief, obstetrics and gynecology, CSS College of ONG and Child Health, Kolkata, vice president, FOXI 2016 to 17, governing council member, ICOG 21-22, past president, the Bengal OBG Society, ex-chairperson, Medical Education Committee of FOXI, the scientific chair of AICOG 2022, which just got over a week back, and we saw the extreme academic knowledge which was flowing through the roads of Kolkata, starting from ITC Sonar to the Hooghly River, and we saw the academic acumen, and he's also the WHO Fellow of Maternal Health. And welcome, Dr. Ashish. Your camera is somewhat inverted. I don't know what to do about it. We are seeing you upside down, and so I know you are looking quite upside down after the AICOG, but we thought we could look straight at you if it's possible. Some adjustment of the camera has to be made. Thank you, Dr. Ashish, for having come in. And the third chairperson is Dr. Sheila Vimani from Bengaluru, DNB professor, KC General Hospital, Bengaluru, senior consultant at the Anugraha Nursing Home, Bengaluru. And who will not know Dr. Sheila?
Enough, Palani.
Thank you, ma'am. Thank you very much. And she's the vice chairperson elect for ICOG. Let me put that, and having you here is an absolute privilege. And so now I hand over to the three chairpersons, and so I can have a cup of coffee for the next 15 minutes or so. Over to Dr. Ashish, Dr. Sheila, and Dr. Jayam Kannan. Let me stop.
Ashish.
Well, thank you, Palani Appan. Since I'm looking inverted, so I think I should have the privilege of
introducing our speaker, and then the comments will come from Dr. Sheila Mane. And as you know that after the AICOG's load is over, everything has to be inverted, including my picture. And that is the reason. Otherwise, I have no ulterior motive or any intention of keeping myself and presenting myself inverted. Believe me, I have no hands in that. However, coming to Dr. Parikshit Tank, our next speaker, well, everyone knows him and he doesn't really need introduction. But for the record's sake, I'll say 3 sentences for him. One, he is the younger son of the illustrious, great past president of Foxy, Dr. D.K. Tank, that everyone knows. But that is for the past. For the present, he is the richest man in Foxy because he's holding the chair of honorary treasurer of Foxy. And for the future, maybe I may be proved absolutely right some years down the line. He is the future president of Foxy. So with all these 3 sentences for Parikshit Tank, I would like to, he's a very, very knowledgeable fellow and extremely good friend of mine. And I would like to invite you for a talk, of course, after getting some initial comments from Dr. Sheila Mane. Dr. Mane, please.
Yeah. I think thank you, Kalpana, for that elaborate
Excellent
talk on
yes.
malaria. And I take this opportunity again to welcome Dr. Parikshit Tank. And I think as Dr. Ashish mentioned, and son of Dr. D.K. Tank, and I must share that I had an opportunity to work with sir, and I had done the WHO workshop for the medical officers. And I think from there, I started my work at the grassroots levels, Sir had a module for the medical officers, and we also, I feel pride to say that we also received the D.K. Tank trophy for the social work. Anyway, all of us, we know Dr. Parikshit Tank, and as Ashish said, the richest person in Foxy. Okay, so we see to it, I think we'll see that the Foxy becomes more and more rich. And regarding academics, yeah, all of us, we know. So we are looking forward to hear you, Dr. Parikshit.
Thank you, ma'am. Thank you so much. Thank you, Dr. Mukhopadhyay, for those very kind words and those very gentle memories of my departed father. Let me begin by expressing gratitude to the convener, Professor Palaniappan, and of course to the ICOG team, the chairperson, Dr. Srikhande, vice chairperson, Dr. Biniwale, the vice chairperson elect, Dr. Mane are all here, and Dr. Ashok Kumar, the secretary, and of course to Team Foxy, all the office bearers. We are very fortunate to meet on this virtual platform. And today's topic that I have been assigned is dengue in pregnancy. And this is a part of a seminar which says infections not always came, but they are sometimes. So let's begin with, a little bit of background. I was chair of the Safe Motherhood Committee in 2014 to 17 in Foxy. And one of the tasks that I was assigned to was drawing up a document on dengue in pregnancy management protocols. And this was 2014. And it was a very fruitful discussion because we did come to some important conclusions about how we can go about identifying, managing, and looking after these women with dengue in pregnancy. So a little bit of background, the causative agent is a viral infection, and it is abbreviated as from dengue virus as DENV. It's a single positive stranded RNA virus. 4 serotypes and 47 subtypes have been identified belonging to the Flaviviridae family. The word flavi means yellow. And actually, the first virus which was described is the yellow fever virus. That's why the whole family is the Flaviviridae. And then, of course, one of them is the DENV. The vector is a mosquito. And the Aedes mosquito, mainly Aedes aegypti, and also Aedes albopictus. These are the ones which carry the infection, and they lay eggs in standing water. They bite in day or night, indoors or outdoors, and the infected bite is the transmission event. Now, how does this transmission occur? See, in urban setups, the transmission is mainly via human to human only. But enzootic transmission, that means from primates also via the same mosquito to humans, is also documented, it is known. And mother to child transmission of the virus has also been found in some cases. Other bloodborne routes, that means infected blood, needles, etc., have also been known to spread the infection. So this is the broad outview about the routes of transmission. Mainly for our practical purposes, it's a mosquito-borne virus which goes from one infected human to the other. And these are some more detailed informations about how this transmission occurs. It's usually a 8 to 10 day gap, which is needed for the extrinsic incubation. That means if a mosquito has bitten one infected human, then it can infect another infected human after 8 to 10 days. So that is extrinsic incubation. And then once this particular host, the new host is bitten, there is an intrinsic incubation of 4 to 7 days. Now, why is this important? Simply because if somebody were to have traveled from a non-endemic zone, then all this information is important. But for us Indians and largely for us Asians, dengue is a endemic infection. So you can't really trace that, okay, I got bitten by a mosquito 10 days back and now that's the source of my fever. No, it doesn't work like that. In fact, the whole of India, Gujarat, Kerala, Uttar Pradesh, Uttarakhand, Punjab, these are all highly endemic areas, and Maharashtra, Karnataka, etc. These are also endemic areas that we are looking at in this chart that we have on the right hand side. The left hand side shows the world prevalence, and globally 400 million infections and about 22,000 deaths annually occur because of this infection. In India, we have 12 million of those infections and 6,000 deaths. The case fatality rate, maternal case fatality rate in our country has been reported to be between 1 and 20%. So this very wide range, it reflects the type of disease that this infection can cause. I mean, it can be a very mild disease and it can range to a very severe sort of infection. So if we look at this entire spectrum of dengue virus infection, of course, it can be asymptomatic. We'll never discover how many asymptomatic infections are there. But the symptomatic ones could be just an undifferentiated fever of a very short duration of 24 to 48 hours, or it may be a documented dengue fever without hemorrhage. It can be a dengue hemorrhagic fever, DHF, which is associated with the plasma leak syndrome, which we'll come to in a minute. It may be accompanied with shock, and dengue fever can be accompanied with hemorrhage. So the syndromes or the spectrum which I'm showing, which are in the colored ovals, the dengue fever with hemorrhage or the dengue hemorrhagic fever, DHF, with shock syndrome. These are the very dangerous conditions that may be faced in any individual, including pregnant women. The rest of the conditions are relatively not lethal, and they may cause some systemic upset, but by far and large, recovery is good from that spectrum. Now, why do we have such a huge spectrum of disease? Well, it largely depends on what is the immune status of the individual, the viral strain which is causing the infection. As I mentioned, there are 47 subtypes, 4 main serotypes. What is the viral load that is being presented to that particular host? The genetic status and susceptibility. Of course, Asians are somewhere in the middle. Black people are protected, whereas white people have a more susceptibility to infection. And the age, extremes of age, you see more morbidity. And the pregnant woman is at an average risk. Neither is there too much of morbidity or mortality, nor is it in any way protective. So the typical clinical presentation, when we consider, the important thing to acknowledge is that dengue has to be a differential diagnosis for all fevers in pregnancy. Think about it as one of the possibilities which may be leading to the pregnant woman coming to your clinic with fever. As I did mention that pregnancy does not affect the clinical features of dengue, but pregnancy features may be mistaken for systemic impact of dengue and vice versa. That can happen. So, you have tachycardia, or you may have nausea. There may be some degree of muscular aches, joint pains, which are very confusing features between an average pregnancy and systemic effects of dengue infection. So this is what we have to watch out for. Besides the fever, there can be symptoms which may be from head to toe, and the characteristic ones really are the joint pains, muscle aches, and the rash, which is indeed quite common. How does the clinical outlook, once the infection has set in, what does the clinical outlook look like? Well, 80% of individuals, including pregnant women, are going to have a mild course of dengue infection, and the fever is there for 2 to 4 days. We generally treat it as some kind of upper respiratory tract infection, or the patient may be presenting even after the main peak of the fever goes, and generally treated with paracetamol or some such measures, tender loving care, as they say. And that's all that will be needed for a large majority of women. So yes, I agree with the topic of the day that not always scary, but 20% of pregnant women or any individual will have a progression, and this is completely unpredictable. You can't really say who is going to have the benign 80% course and who's going to have the dangerous 20% course. Again, pregnancy, labor, breastfeeding does not seem to have any significant impact on disease progression. It's not as if a woman who has just delivered is more susceptible and more likely to have a complicated clinical course. It's all the same. It's quite thoroughly unpredictable, really. And they would go through these stages of dengue hemorrhagic fever based on the level of thrombocytopenia and hematocrit which have been described and the clinical features. Just for the postgraduates who might have joined, there is something called a tourniquet test which you may do. Inflate the blood pressure cuff to a point midway between the systolic and diastolic. So say roughly around 100 millimeters mercury, and wait for 5 minutes, deflate the cuff. If there are more than 20 petechiae or small red spots in 1 square inch of skin, that is a positive tourniquet test, and this is quite characteristic of dengue hemorrhagic fever. Now, practically speaking, nobody does these kind of tests, but examiners like to ask these type of questions in the exam, and therefore it's useful to be knowledgeable about these things as well. Of course, what we would rely on are the lab features and the clinical course to judge how things are going. So if you look at this very beautiful chart, it tells you exactly what to expect. And this clinical course is important to predict for pregnant women because it will allow you to understand what kind of recovery is going to happen. So the critical part are the first 5 days of the fever. So if you notice, the woman becomes febrile on the day of presentation, and this lasts for 3 to 4 days. Usually after the 5th day, there is no fever. What are the potential clinical issues which may come up? Well, if it is the early phase, there may be dehydration, and she may be hypovolemic. There may be renal impact because of this hypovolemia. If we look at her in the critical phase, there can be shock or bleeding, which can happen. And rarely in the recovery phase, in the first 1 week to 10 days, there may be a fluid overload and the woman may present with pulmonary edema or with gross ascites, which may also be seen. Similarly, the platelet count will fall to the most minimum level on day 3 to day 5. and then start recovering after 5 days of the fever having started. Just to understand the lab tests, there is a viremia in the first 3 days, and then the antibody response kicks in. We'll look at it a little later in the next upcoming slide. So what's important to understand from this clinical course is that most people will recover from dengue fever in about 5 days or so. Roughly 5 to 6 days is the time when they should be past the critical phase of the disease. How do we make the lab diagnosis? What is very commonly available is dengue NS1 test, which is a viral test. The non-specific structural protein 1, that's what NS1 stands for. And that's when the peak of viremia is there. That's when you're going to be able to detect it. So on day 1 of the fever or day 2 of the fever, the test may be negative. But day 3 to day 7 onwards, you will find a positive dengue NS1. Later on, again, the viremia drops and you're not going to get a positive test. Then if you want to make a diagnosis, you've got dengue IgM, which is positive from the 5th day onwards for about 3 weeks. After that, dengue IgG will tell you that there is been a past infection. That's really only for academic purposes. If you want to document that, okay, this particular fever that a woman had in pregnancy was because of dengue or not. But it's hard to make that diagnosis. As I said, we are endemic, so you may have old infections where the dengue IgG still comes up positive without any features at all. We need to do a hematological and a coagulation status, understand what is the biochemical impact. This is especially for women who are sick. You'll do a liver and a renal function test, and then do appropriately timed fetal well-being tests, depending on where this woman is in pregnancy. So this is an algorithm which we can use. Every pregnant woman with a fever at least should be considered for admission. And once the diagnosis of dengue is there, then definitely admit this woman to monitor her and to look at how she's progressing over the next 24 to 48 hours. Look at the fluid intake and output. If she has adequate intake or not, you can avoid IV fluids. If not, you can give a fluid challenge and see how the hematocrit behaves. Of course, if there is a more severe type of disease, then we'll come to what to do. As I said, admit all pregnant women, monitor the symptoms and clinical evolution of the disease. If there is a mild disease, no systemic involvement, normal labs, just oral hydration 2 to 2.5 liters per day and paracetamol up to 2 grams per day is enough. That's all the management that you need. Avoid IV fluids, especially an overload. Avoid other type of NSAIDs and intramuscular injections, which can cause hematomas. Mobilize her, but see that this woman gets adequate rest, because recovery from a viremia does take 3 to 4 days. So no need for a complete bed rest, but there should be some rest element in the management. If it's a severe dengue, then the recognition and care are important, because the recognition is something which we might easily miss. Abdominal pain, tenderness, vomiting, fluid accumulation, mucosal bleeds, lethargy, and organ enlargement are all features of severe dengue. And here, I think it's better to involve a physician, give adequate fluids in the form of normal saline or Ringer's lactate, no dextrose, please. One may consider catheterizing this individual because you want a strict watch on the urine output. And this is the phase where one golden rule has to be followed. Don't be in any rush to deliver this woman or operate on her. Some women will present with a severe syndrome of plasma leakage and a dengue shock-like picture with respiratory distress. There may be bleeding. This requires ICU care, hematological corrections, and organ-based support. One simple rule as far as obstetricians are concerned, dengue means delay the delivery. Just remember this. Any planned delivery for 7 days from the onset of fever, don't deliver this woman. the woman should be afebrile for 24 hours and the lab parameters should have recovered, especially the platelet and the hematocrit should be normalized. Only after that you plan your delivery. What if the woman comes in preterm labor? Well, you can use tocolytics, but avoid beta mimetics and a fluid boluses. Nifedipine and atosiban can be used. Antenatal corticosteroids can be given as usual. If you're planning to give magnesium sulfate for neuroprotection, then give it intravenous rather than intramuscular. If the delivery is inevitable, there's really nothing you can do. This woman is 4 centimeters and she's had fever since 2-3 days. You know it's dengue. Deliver her in a tertiary care institute with adequate blood and blood products available, including single donor platelets. That's the ideal thing what you would need. A cesarean is not mandatory. As per the obstetric condition, you can decide the route. You'll have to monitor the labor, the mother, as well as the fetal condition. Again, avoid fluid boluses because they may go into overload. There's no role for intravenous steroids or immunoglobulins to boost up the platelet count. What should be the transfusion triggers before delivery? If before delivery, less than 50,000, definitely you're going to give a platelet transfusion. If you can, give an SDP, and this will hold for about 4 to 6 hours. So don't give it too much in advance of the delivery. In fact, what we usually do is that when the antibiotic is being given, you give the platelet along with that and then make the incision within half an hour. Above 75,000, you don't need to do anything. That much platelet count is enough for the delivery or the regional analgesia, whatever you want to do. 50 to 75 is a gray zone. Some anesthetists won't give a regional unless it crosses 75. So in that case, you may have to transfuse. After delivery, your threshold can become lower. Even if it is 50,000, you can just afford to wait and watch. Don't do anything until it hits 20,000 or so. That's quite reasonable. Perform active management of the third stage, but yet be ready for PPH. And you are going to face this kind of a situation 1 out of 5 times when you're dealing with an active dengue hemorrhagic fever in delivery. So, of course, we know the prevention tips: eliminate standing water, repellents, more of indoors and protective clothing, mosquito nets. And hopefully we might actually have a dengue vaccine, which might launch in our country in the near future. So once again, thanks for this opportunity to share some thoughts about this fairly critical infection in pregnancy. Thank you.
Thank you, Parikshit. I think when we face this situation, we could see some critical cases because the diagnosis used to be late and only looking at the platelets. But as you know that there can be an internal bleeding also, and we have seen patients coming in very critical conditions. Yeah. So I think that's what, during cesarean particularly, we had to take some precautions because sometimes there could be bleeding from the wound. So keeping a drainage tube was advisable those days, because sometimes intraperitoneal and even subacute, because there could be bleeding. Yeah.
One
so
could,
that was
one could do that. Yes.
Yeah, that
there is a tendency for seroma collections, and I've actually had a need to, in fact, explore a woman after 6 days of a cesarean. She had been brought with compartment syndrome. Actually, there was so much of ascites because she had been operated unknowingly when she had dengue, and then she had gone into a bit of a critical phase, lot of fluid accumulation, and she had a compartment syndrome. Fortunately, she did well. We could drain the peritoneal fluid. We left a big bore drain in the below the rectus sheath, in the peritoneal cavity and above the rectus sheath, and she did do well. But she did give us some sleepless nights.
Yeah, I had a patient who had, in fact, bleeding, muscle bleed, and we had to explore
hematoma
her.
can also happen.
Yeah, hematoma. So we had to explore her.
Yeah.
So thank you
Can
for
I say
excellent. Yes,
Can
Dr.
I say
Jayam.
something? Yeah. Parikshit Tank is a very silent worker. he had added 200%, 100% of tank, 100% of his brother. And his viral load is very heavy. And I am going to see it very much in the near future. The high mortality which he has given is one thing which everybody has to worry. When the fever crosses the 4th day, it is a time when which we always get worried, because it is not the fever, it is a hemorrhage and shock, which you have very clearly pointed out, because we are not able to pinpoint it. The best day is always day 4 to test this, which you have clearly brought it out. And you have talked about this positivity test, which is always for the examiner to get satisfied, not for us to do anything. Yes, very nicely presented. Keep it up. Grow more, Parikshit. We wait for the questions from the
Thank you.
delegate.
How much more he will grow, madam? He's already grown too much.
No. It is only 200% of this thing. He has to grow more, no?
Okay.
He's quite young enough. Not he's not Ashish now, no. Ashish is standing upside down. He's still like all of us, standing.
The pressure of ICOG, madam, is on, huh?
No pressure. All of you were smiling so nicely. I saw you 4 times on day 1st. And saw you 3 times on day 3rd.
It was a pleasure
and
meeting
last
you.
day I met you 2 times.
Thank you so much. Parikshit,
you,
excellent talk as usual. Very good. Excellent.
Thank you.
Thank you.
Jem ma'am, can you introduce Dr. Krishna Kumari Jem ma'am?
Yes. Coming to Dr. Krishna Kumari, who is a very close, lovely friend of mine from Telangana. I love her academics, silent academics like Dr. Parikshit Chand, because she has been a medalist even in her MD. She has not put about her MBBS, but she has been a medalist in MD. That means consistently she has been working right from her student days till this day, and her work during this Shantakumari's period has been excellent, with great academic input. And I have seen her as a president of Oxy Society. I have gone and presented papers there. And we would like to see her more in the next conference as a scientific committee chair also, I think so. And today she is going to speak on a very, very important topic. Over to Dr. Meka Krishna Kumari. The platform is yours.
Thank you. Thank you so much, Madam. You have been as sweet as always. And it's always a pleasure to meet you anywhere and everywhere. And it always gives me a smile on my face. And we always admire you for many things, some on the record and some off the record. But still we admire you for many things.
Thank you.
It's lovely. Thank you for your kind introduction. And good evening, chairpersons and all the people listening to us. At the outset, I would like to thank Dr. Lakshmi Shrikande, Chair of ICOG, and all the team of ICOG for permitting me or asking me to present. And thank you, Palniappan, for he told me, well, you have 2 days, it's enough for you, you have to present. So I hope I'll be able to do justice within the last 2 days of what I want to bring to everybody's notice regarding HIV in pregnancy. So can I share my screen? So am I visible, madam?
Yes, ma. You are perfectly visible.
Yes, okay. So my topic for today is HIV in pregnancy. So I would be going through the introduction of HIV and PPT-CT services in India. What is the need for giving ART and ARP, and some unusual circumstances which we should be aware of, although we don't have a control of. So coming to what HIV is for us, why we need to know about HIV is because in the absence of any intervention, the chances of infection of HIV exposed children can be something as high as 25% for type 1 and 4% for type 2. And we know there are 4 prongs to the prevention of mother-to-child transmission. That is primary prevention among women of reproductive age, and prevention of unplanned pregnancies, and prevention of HIV transmission during pregnancy, and also treatment, care, and support of HIV-infected women and their families. So although a great job has been done in trying to control it, the rate which has been brought down from 2010 from 40.2% to 27.4% in 2021 is still much higher, because our target is still only 5%. So we all know there different interventions lead to different risks of transmission. When nothing is done and the woman just breastfeeds, it is as high as 30 to 45%. And there is a decreased risk of HIV transmission as long as we start on ARV and keep on decreasing the risk of by asking them not to breastfeed, or we give other alternative feeds. Single ARV, it is higher, 5 to 15%, even though they don't breastfeed. With 2 ARVs, even breastfeeding, it is 5%, whereas 3 ARVs, that is 3 drugs and breastfeeding, it is 2%, and 3 drugs with no breastfeeding, the risk is 1%. This tells us, gives us an idea in about how we can counsel the patient about what they want to do and how they should go about their management, and how they should fall in line with our plans for them to minimize the risk of transmission. So as far as we are concerned in our country, our targets are, what we want to do is we want to bring more than 95% to be registered for antenatal care, at least have one antenatal checkup, and 95% of these women should be tested for HIV, and 95% of HIV positive pregnant women should be treated, kept on ART. So this is what we are looking at to eliminate mother-to-child transmission in our country. So although this slide looks a bit crowded, how all the points are essential. Basically, like I said, the opt-out option is what we have chosen for all our antenatal patients. And then it's very important that we are moved now from the antenatal care centric to a family centric. That means we involve the spouse and other family members also while counseling and while talking to them for any purpose in the antenatal period, and also provide lifelong ART irrespective of CD4 count and clinical stage. So now what we are aiming at is a lifelong ART, and also give the needed attention and treat conditions which are associated like STIs, RTIs, tuberculosis, other opportunistic infections, so on and so forth. And we would like all of them to deliver in the institution, and we want them to have viral load testing at 32 through 36 weeks, because if the viral load at 32 to 36 weeks of gestation is minimal, that is less than 50 RNA copies per ml, then we are going to put the babies under low risk ARV prophylaxis. And otherwise, the ARV prophylaxis goes as per the guidelines. Then, of course, nutrition counseling, psychosocial support is very important. And we have to talk about the breastfeeding from a very important aspect, and we know the additional advantages, disadvantages of breastfeeding, and when they should and when they should not. They can choose to breastfeed as long as they have a proper, they are properly adherent to the ART, and their copies come down to the non-detectable levels. And also we have to integrate the following up of these exposed infants into routine healthcare services, including immunization, and ensure that if necessary, we give a co-trimoxazole prophylactic therapy and minimize their chances of getting affected. Community follow-up and outreach also is very, very important. So coming to the labs, sometimes we all know that the first test is done when the patient comes to us at the first visit, once we confirm pregnancy. So do we have to repeat it at later time? You may have to repeat it in the last trimester or at more frequently if you think that the patient is at higher risk of again acquiring the infection, or she belongs to a place where there is a high prevalence. So then that is where we have to repeat the test, because we all know that there is a window period. ELISA is normally the test done. It has a sensitivity of 99.5%. Then once if it comes positive, we confirm by Western blot or the immunofluorescent assay. These tests have high specificity. So if the patient is coming with an acute primary infection you want to detect, then you have to do either viral P24 antigen or viral RNA or DNA. These are more sophisticated tests, more costlier tests. If the patient is coming with an unknown status at delivery, then you do a rapid test, like we all know about the rapid test of COVID. Similarly, we have to do a rapid test for HIV. The report should be out within 1 hour. And CD4 count, if it is less than 200, or CD4 lymphocyte percentage is less than 20%, or beta-2 macroglobulin is more than 3.5, then this means that this woman is at high risk of progression. Then the other factors which affect the transmission are viral genotype, viral resistance, viral load, and of course, as we all know, the low CD4 counts. So at least they should have 1 CD4 cell count at baseline, and again 1 at commencement of CART, and 2 to 4 weeks after commencing CART to see if they are responding to your treatment, and 1 before delivery to see whether it is effective after 36 weeks, at around 36 weeks, which will give us a guidance whether it will be whether the baby comes under the high risk category or the low risk category. For women who come in CART in pregnancy, you have to do it more frequently to see if they're responding to your treatment or not. And LFTs should be performed more than necessary, because we may also not only be affected by the drugs, but also the complications of the pregnancy itself can add to the disturbed LFTs. So then there is another newer, this is from the CDC guidelines. All the previous guidelines have been from the NACO guidelines. This is from the CDC guidelines. There is something known as a pre-exposure prophylaxis. So I think we are not yet, at least I'm not yet into this, because of our Apollo Medical College has been recognized as one of the national ART centers where we have the one of the centers where we disperse drugs to all the HIV positive individuals, as well as we do deliveries for HIV positive women. So here we are not yet into pre-exposure prophylaxis. So here for uninfected individuals who are trying to conceive or are pregnant, postpartum or breastfeeding, so to prevent the HIV acquisition, we can ask them to have a pre-exposure. We can counsel them regarding pre-exposure prophylaxis. This is more important, for example, in discordant couples. So when these, when the women are having condomless sex with a partner who is with HIV, who doesn't know his HIV RNA level, or the levels are high, or there is a recent history of STI, or they are into injection drug use. These are people who are at high risk. So you can counsel them that when they're planning the pregnancy, maybe they should go ahead and start with a pre-exposure prophylaxis. So, and once they start that, they go ahead and continue it throughout the pregnancy, which gives them a 90% protection against acquiring HIV. And you keep testing for HIV every 3 months. And if you think there is an acute retroviral syndrome, you shift over to the test comes positive, shift over to the regular management. And also, when the drugs which we use for PrEP are the TDF, recommended are the TDF and the that is the tenofovir and the emtricitabine. And for that, you need to be sure that the renal creatinine clearance is not less than 60 ml per minute. So coming back to the actual management of treatment for HIV in pregnancy, we understand that there are 3 ways in which we can provide ART. That is, we are continuing treatment for a woman who is already on treatment, or first detected in pregnancy where we are initiating treatment, or a woman who is on ART, but the levels have not, the copies have not come down. It is still positive, and we need to modify the drugs, not only because of the levels, but also because certain drugs may not be of effect in due to the different pharmacokinetics of pregnancy. So these changes have to be made according to the patient, and all HIV positive pregnant women who are presenting to us at any time in labor or breastfeeding should be initiated if they are positive on a triple drug ART, regardless of CD4 count and clinical stage. That means you're treating all women who are coming to us and at any point of time in pregnancy and detected to be positive. This is not only for preventing MTCT, they should continue with this ART for lifelong. And the backbone for this treatment is a dual nucleoside analog reverse transcriptase inhibitors, that is NRTI. Then we add to it the ritonavir boosted protease inhibitor or an integrase inhibitor. So the NRTI is a basic backbone. So if the woman is already on effective CART regimen, that is C means combination ART regimen, you continue with the same treatment unless she is on some protease inhibitor monotherapy, or like I told you, the pharmacokinetics do not match, are not comfortable in pregnancy, then we may have to change the drug. The British HIV Association has wonderful guidelines. It is 500 and odd pages of HIV. People who are really interested can go through these, through all that. And they say that all pregnant women, including elite controllers, the word elite controller means that this woman, in spite of not taking any treatment, is able to bring down her viral load. They should start ART during pregnancy and be advised to continue lifelong treatment. And who are not on combination ART should start the combination ART as soon as they're in the second trimester, at least, if the viral load is less than 30,000. And if it is between 30 to 100,000, immediately after the starting of the second trimester. If it is more than 100,000 RNA copies, then immediately, even in the first trimester, they should start. And the last cutoff point is 24 weeks of pregnancy. By then, everybody should be definitely on CART. This is a chart by our NACO guidelines. So the woman gets registered at ART center, then they initiate the ART, and then they put them on, they do the viral load test between 30 to 36 weeks, then they ensure institutional delivery, and then infant prophylaxis. Whereas if they are already on ART, that is the recommendation now which we are giving in our country, the NACO guidelines is the TLD regimen. And you do a viral load the same way and the institutional delivery and then ARV prophylaxis as per the risk. Then patients who come directly in labor, you do a HIV test before you get it confirmed, start the treatment, and then wait for the confirmation. Once the confirmation comes, you can link them to the ART center and take it further from there for both the mother and the infant. If they are detected postpartum, you have to link them to the ART center immediately. And then regardless of CRD4 count, they are again started on ART, as we have already, similar to the BIVA guidelines. So again, you give the infant prophylaxis. So what we are doing in our country right now is, if the patient is pregnant or breastfeeding, we give the TLD combination, that is tenofovir, lamivudine, and dolutegravir. These are the 3 drugs which are being given as a single tablet once a day for all, for whether it's HIV 1, 2 combination, a single dose. Already they have been exposed to single dose nevirapine in the past, co-infected with tuberculosis or hepatitis, and they should be educated about benefits and risks before, and we have to take an informed choice and then go ahead with starting the treatment. We have to, there have been at one point of time, dolutegravir was supposed to be associated with increased NTDs. Now we don't think so. It has not so much as was thought. But to be on the safe side, for all patients who are on dolutegravir less than 12 weeks, give them 5 milligrams of folic acid, whereas for others we give just routinely 400 micrograms as recommended up to 12 weeks of pregnancy. So when you are starting combination ART, you counsel the patient, and two of the studies, major studies have shown that zidovudine doesn't make a difference in pregnancy outcomes, whether it is zidovudine based or zidovudine sparing CART. It is, but monotherapy we do not recommend until the patient insists and she has a viral load of 10,000 HIV RNA copies per ml, and she should be willing to go ahead with the cesarean section. So the BIVA guidelines, as you have seen, they also recommend the same TLD. Recommended is abicavir or lamivudine, tenofovir, and or emtricitabine. And the third agent is efavirenz or atazanavir or with incorporated with ritonavir. But as you can see now, even they have also shifted to everybody is shifted to dolutegravir as a third agent, which is usually started after 6 weeks of gestation. So women who are presenting late and not on treatment, that is after 28 weeks, still you start them on CART without delay. If you do not know the HIV, the load, then give a 3 or 4 drug regimen, which includes raltegravir or dolutegravir as suggested. So if the patient is presenting to us directly at term, you can give a start dose of nevirapine, then give the loading dose, and also give intravenous zidovudine for the duration of labor. If the patient is, if she is in preterm labor, the infant afterwards may not be able to absorb the medication. So give a double dose tenofovir for these women when patient is in preterm labor. So there are certain recommendations for intravenous zidovudine, that is when the viral load is more than 1,000 HIV RNA copies per ml, who are presenting in labor or with spontaneous rupture of membranes or admitted for preterm pre-labor cesarean section. So also for women who are not treated and presenting to us in labor or with spontaneous rupture of membranes where we do not know the viral load, or for women who are already on treatment, but the HIV viral load is between 50 to 1,000 HIV RNA copies per ml. So we also need to remember that there are different issues regarding the drugs. There can be side effects. The most important is the adherence. There can be drug reactions. There can be teratogenicity, and there have to be dosage adjustments. All these have to be looked into when you are giving them these antiviral drugs and looking for an appropriate treatment. Suppose after treatment it does not come to less than 550 HIV RNA copies per ml, then you have to think of maybe you have to review the adherence. You have to do what we call as a resistance test. The resistance test tells us if the drug is appropriate, the virus is sensitive, or if there has been any change in the genotype of the variant of the virus. Then you have to consider therapeutic drug monitoring may have to be considered and optimize to the best regimen, and consider intensification with therapies which cross a placenta, such as double dose tenofovir or a single dose nevirapine. These have to be thought of when you are changing. Antenatally, you need to have a multimodal therapy, fetal ultrasound imaging, NIPT, as per the guidelines in spite of the maternal HIV status. Invasive testing should be avoided unless you suppress the viral load to less than 50. External cephalic version also should be done, only any procedure done when the viral load is very, very minimal. The other important aspect is looking into the psychological aspects. You are very much prone to antenatal postnatal depression. You have to go on repetitively looking at their psychological aspects at booking, after postpartum, and even much later. Not only that, there is an increased risk for other STIs, and their sexual health screening is recommended for all these women. The mode of delivery, we have, if the cesarean section is not mandatory, and for women where the plasma load is again less than 50 at 36 weeks and no other obstetric indications, you can go ahead and do a vaginal delivery. If it is more than 400, you have to go at 36 weeks, go ahead and do a C-section. And this C-section is done between 38 and 39 weeks. When the copies are between 50 to 399, it is a gray zone, and you have to take into account the other things like the trajectory, the length of time on treatment, the adherence issues, obstetric factors, women's views, or multiple factors come into play. So only after 400, it is definitely you can have to go ahead with a C-section. Less than 50 at 36 weeks, you can plan for a vaginal delivery. And vaginal birth after C-section again should be planned only if the copies are less than 50. If the woman is coming to you with a spontaneous rupture of membranes, the aim should be to deliver within 24 hours. Again, if the copies are less than 50, you start immediate induction or augmentation. Beyond 50, I think it is not ideal to go ahead with the vaginal delivery. And when there is a premature spontaneous rupture of membranes, you may go ahead and give intramuscular steroids if the gestational age is less than 34 weeks. But you have to go ahead and have a multidisciplinary discussion and regarding the various aspects. Infant feeding, we all know the formula milk with cabergoline to suppress lactation is ideal. But then when it is women who are virologically suppressed with your treatment with good adherence and choose to breastfeed, you should support them. And we should tell them that the risk is very minimal, low risk is there with breastfeeding. And the requirement for extra maternal and infant clinical monitoring has to be emphasized. You have to repeat it, HIV RNA viral load every month in your clinic and 2 months after she stops breastfeeding. So we also have to continue with the CART. And categorizing the infants into low risk and high risk is very, very important. And if they are low risk, we are giving either syrup nevirapine or syrup zidovudine for the next 6 weeks. If they are high risk, belong to the high risk, then we have to give a dual prophylaxis with both of the syrups. And in case of exclusive replacement feeding for 6 weeks and breastfeeding for 12 weeks of gestational age. So we have, based on whether they are non-breastfed or breastfed, you have to go on repeating their levels. So molecular diagnostics for HIV infection should be done at the first 48 hours, 6 weeks, 12 weeks, and if necessary, again repeat them as and when necessary. And antibody testing also has to be done if the mother's antibody is not documented. Otherwise, you do at 22 to 24 months to see for any seroreversion. And again, the same thing for breastfed infants, you continue monitoring for at least 8 weeks after cessation of breastfeeding. And again, antibody testing, the protocol is the same. We're looking for seroreversion at 24 months. So for infants now, suppose in spite of your ARV, they are coming positive, then you have to refer them to a specialist center, and you maybe start them with the cotrimoxazole prophylaxis. And of course, whatever is happening there, you need to take the feedback so that you will know what is happening with your babies. We also have to understand the co-infection with hepatitis B, C is very common, and there can be a confirmation of viremia with quantitative DNA, whatever the status, we have to quantify it and then confirm and then look at the liver aspects of it. Tenofovir and emtricitabine or lamivudine are the backbone of treatment regimens when we have these combination. If they are, if it's necessary, we can go ahead with the HIV vaccine. And if they are planning pregnancy, we need to do direct antiviral anti-HCV treatment. Based HCV therapy should be given and it should be expedited. So as far as HIV and COVID is concerned, they have to have 3 vaccine doses. And in spite of that, response might be much lower because of the damaged immune system, and sometimes may have had to take 4. And on 21st February, the Joint Committee on Vaccination and Immunization has recommended that for any person who is more than 12 years and who is immunosuppressed, you should offer a booster after every 6 months after the last vaccine dose. So this monitoring of pregnant women, you should revert to routine regular visits. And infant testing, we have already said. And breastfeeding should be supported with adequate testing as and when required, as already discussed. Women should continue to take their combination ART post-delivery. And if you are not, if they are active against HPV, HCV, and HIV, you should continue these medications even postpartum. Contraception, dual protection, DMPA, hormonal contraception, if CD4 is more than 350, can be given. Only COCs are contraindicated if you are giving ritonavir-based protease inhibitors. Male sterilization is a good option. And for women who are newly diagnosed with HIV in pregnancy, you have to check the partner and other children. Then cytology, you should never, you can wait till 3 months post-delivery if you are, if it is not an urgency. But if there has been a high-grade abnormal cytology, go ahead. If you need it, you may have to do a colposcopy. Or if it is a first test where they are having a CIN, you have to go ahead and finish with your colposcopy. And the test of cure appointment also should not be delayed if it is a CIN 2 or 3, especially when the margins are not clear. The newer problems we have is regarding trans women and non-binary. So the knowledge about this is very, very minimal. It is appropriate to extrapolate whatever the recommendations have been now made based on data and presumed cisgender women to all people assigned female sex at birth, including transgender and gender diverse people with modification when indicated. So we have to understand that they are having gender affirming hormones and drug interactions would be different. So a detailed, a little more details, although the amount of knowledge is very minimal, a little more details are available on the British HIV Association guidelines, VIVA. Another important aspect is the intimate partner violence in pregnancy. They should, all women who are suffering with HIV have an increased exposure, should be asked about domestic violence. And these are the women who have worse adherence and always more likely to be under depression. So I would like to conclude by saying, by reading out from this very interesting article. In that it says that in India, pooled HIV prevalence of MTCT is as high as 8.78% among babies born to infected mother, and it warrants urgent need of focused intervention for providing ART, ensuring proper infant ARV. So ART, infant prophylaxis, and avoiding delivery without proper medical facility to pregnant women with HIV for reduction of occurrence in HIV transmission for mothers to children. This concludes about what we know. What are the drugs for ART? What are the best drugs for ARV? Keep on revolving. We keep on adding as the knowledge improves. But what we need to understand, these are the basic things which we have to take care of in all the women in our country at least. So my references are from the NACO, the British VIVA, and the CDC clinical practice guidelines. With this, I would like to thank all of you for your patient hearing, and thank you one and all.
Lovely, crisp presentation, Krishna Kumari. You have gone through just HIV in pregnancy, right from the beginning to the ongoing fetal origin of adult diseases, in which we are now not talking about 280 days of pregnancy, 6 weeks postpartum. We are talking about 1,000 days of pregnancy follow-up. So you have talked about it. Probably in 1991, when I had the first patient of HIV in a Muslim, I was so much shocked. And at that time, the microbiologist from Chennai called me and thrashed me for saying, why did you tell the family and send her? How can I send a 19-year-old Muslim girl from Tiruchirappalli 300 kilometers to Chennai alone? Now, of course, last week I had another HIV couple who delivered a baby. So I have been having about 30 years of HIV association. And of course, Lakshmi Srigandi's association in HIV is remarkable. The first conference in which I came to know about Lakshmi was the HIV conference about 15 years ago. And you have brought it down very nicely. And everybody who has seen this should understand that it is a disease which is now not a bad one, as we have been young doctors treating it. Now the youngsters should boldly accept a HIV couple and start giving their treatment. So over to Palniyappan for or any other comments for the
Thank you, madam.
audience
Any other
to take a
comments? You're
question.
welcome. Audience can have questions, and I'm not able to see any questions on the chat
I
box.
too did not see.
Yeah.
Only our comments and appreciations were there.
Yes, Sheila, madam. Yeah.
Probably Sheila
Dr.
and
Krishna
Ashish.
Kumari, excellent talk.
Thank
And
you. Thank
you
you
are
so
also
much.
in a medical institution. All of us, we know now that the stigma is not there. And what we write on their card is like people living with HIV. We write the short form.
Yeah,
you know?
PLHIV.
Yeah. So that is the terminology which is used now. So everybody is also comfortable. And I must tell you, even in public sector, people are so comfortable. They are so open. And, we are seeing parents coming with their children. I mean, some of them are positive, even educated class. So that stigma is not there. And I think all the public sectors are doing excellent work. Okay. I mean, they have the track of the patient, and I do take this trouble to go to the place and find out that how many patients are registered. Like the KC General Hospital where I work, I found out that almost they have 5,000 people who are taking medications from them. And every month, I think they have some 10 to 15 pregnant patients. Okay. And there are protocols which everybody in, particularly in public sector, they really follow it. They know the recent guidelines, they are updated about that, and they see that immediately nevarapine is given. The pediatricians are also aware. So I think great work is happening. And I also see nowadays, because the center happens to be next to the antenatal, I think the health workers in from the community, as well as we see transgenders also coming there and taking treatment. So I think the stigma is gone and the people do come forward and they take the treatment. I think that is the positive thing which has happened, because and nowadays and nobody is scared, like everybody is willing to do. And the next thing happening is now they are coming for hysterectomies now. Okay. So now we have so many patients who are already, but they are living with it. So we know that they are aware about everything except that they have some other comorbidities. So that is the positive aspect of that. And thanks to NACO and thanks to, I think, Government of India, great work has been done for this. So I think, and your lecture was awesome, I think. You have almost covered. And one important thing you told about the cervical cancer screening. I would just like to know, do you think that all of them should be vaccinated with
Yes.
the HPV
But,
vaccine?
I mean, they should be vaccinated, but how far the vaccination is going to be effective? So we would still continue with whatever is needed as by doing the regular pap smear. Screening is more mandatory in them, I think.
I think we should be doing it every year for them.
Yes,
not like the others, but every year. Okay?
Very true. Very true.
Yeah. Because I have a group D who is in our OPD. She is diagnosed with this on treatment. Then we diagnosed her CIN3, and then we treated her. But because of her condition, she has come back with recurrence. And now again, she's undergoing radio and chemo. But all of us, we give her a lot of emotional support. So where she's working, we try to give her a light work, and nobody's trying to discriminate her. So I think that is the society scenario today. Yeah. Thank you.
Thank you. Thank you very much, Dr. Sheila. Thank you, Madam Jayam, Madam, as usual. And thank you, Palniyappan, for your invitation. I hope I have been, I lived up to your expectations. Thank you.
Absolutely.
Yeah, very much rather. And Kalpana's talk on malaria was also excellent, because still we can't say that we can get away with malaria in India. Dengue is, of course, a hi-fi problem, but malaria is a common man's problem. And any fever which is at least a gap of more than 14 hours in between, one has to think of some variant of malaria until we say that 10 years we have passed without a case of malaria. Thank you,
ma'am.
Pradyapan.
Thank you, ma'am. With that, we thank the three chairpersons, Dr. Jem Kannan, Dr. Ashish, and Dr. Sheila Mane for their valuable contributions and sparing time to come to the ICOG Masterclass. And I appreciate the efforts put forth by the three speakers, Dr. Kalpana, Dr. Parikshit, and Dr. Krishna Kumari for their wonderful lectures. And thank you very much, all six of you. And there have been a lovely audience. Should I say that because they've not asked questions? Not so, but they've logged in. And thank you very much, audience. And we move on to the next session for the day. And thank you, the first three chairpersons and speakers. Thank you very much. We move on to the next session, and let me have the privilege of inviting the two chairpersons for this session. The first one is Dr. Shobha Gudi. Dr. Shobha N. Gudi is the Professor HOD St. Philomena's Hospital, a PG teacher and examiner from Bengaluru, and she's the chairperson of the Family Welfare Committee of FOXI 222, President BSOG 2018 to 19, and she's the Lakshya Project Assessor of the Government of India, board member of the FPAI and peer reviewer for our own Jogi, and she's editor for obstetric hemorrhage, and she's got various awards and credits to her name. And welcome, Dr. Shobha, for this wonderful session on the masterclass of ICOG. The next chairperson for the day is Dr. Bharati Maheshwari from Meerut, if I'm correct, Muzaffarnagar, Professor and Department of Obs and Gynae, IVF, Muzaffarnagar Medical College, Chairperson FOXI MTP Committee 2018 to 2020, and the Fellow of the ICOG, and Joint Secretary of the UPCOG. And welcome, Dr. Bharati, to take over the second session and conduct the proceedings. Over to the two chairpersons.
Thank you. Thank you.
Thank you. Thank you. Can we have the first speaker CV, please? Bharti, shall I introduce Dr. Sarina, madam?
Sure.
Thank you, Bharti. So it's first of all, let me thank dear friend Dr. Palaniappan and for inviting me here, and of course, Dr. Lakshmi Shrikande, Dr. Rishikesh Pai, and the entire FOXI ICOG team for this really, I must say, it is coming across like a masterpiece, the infection problem in pregnancy, so highly relevant. It is a privilege for me to introduce Sarina madam. I have known her for several years now, both as faculty for our Bangalore PGCME, plus when I go to Thrissur as a faculty, as a teacher, I have found her to be a very assiduous, very dedicated teacher. Madam is, of course, has been teaching since several decades now, has been a very prolific author, has got a very intense research mind. She has, of course, organized several conferences, especially vaginal surgery, ultrasound and endoscopy. She is the president of Thrissur OB-GYN Society currently, and also the scientific chairperson for the AICOG, which was held in Kochi. Several chapters to her credit, several awards to her credit, and one of them, which I particularly am impressed, is the Times of India Economic Times Award for Most Inspiring Doctor. Welcome, and the subject you have been assigned, I think it is of paramount importance because urinary tract infection can become so complex in our everyday practice. And with your astute clinical, judgment, I think we are very eager to listen to you on the subject. Welcome, ma'am.
Thank you, Dr. Shobha. I'll just share my screen. Can you all see the screen?
Yes, ma'am. No, ma'am. Screen is not.
Now, can you see?
No, ma'am.
I think, ma'am, you have to first open the presentation on the
Yeah, I have opened the presentation.
Yeah, to minimize it and then share. Yeah. Yeah,
Yes,
madam.
ma'am,
Now.
now.
Yes, yes. Now.
Yes, ma'am.
Yeah,
now
yeah.
it's seen.
Yes.
Thank you. At the onset, let me thank Dr. Palaniappan for having given me this opportunity of taking part in this great masterclass. Dr. Rishikesh Pai, our president, Dr. Lakshmi Shrikande, chairpersons, Dr. Shobha Goody, my very dear friend, and Dr. Bharati, and all my co-colleagues and ladies and gentlemen. I've been assigned this topic, urinary tract infection in pregnancy. As Dr. Shobha was saying, this is probably something which we come across so often that many of us do not give it much of importance, taking it for granted. But I think it has got its own importance. And I'll tell you why, okay? So diseases of the urinary tract are common in pregnancy. And this is because of the structural and functional changes seen in pregnancy in the urinary tract. The risk factors for UTI in pregnancy is because of the hormonal and the mechanical changes which lead to urinary stasis and the vesico-ureteric reflux in pregnancy. So once you get a cystitis, there's a reflux and you're bound to go in for an upper UTI infection. Because of the short urethra seen in females, diabetes seen in pregnancy, many people with sickle cell anemia land up with asymptomatic bacteria and a frank cystitis. Again, we see that the increased chance of UTI is because, as I was telling you, the short urethra and the close proximity of the external urethra to the area heavily contaminated with bacteria. All of you all know vulvovaginitis. Many times patients itch over there, and because of the close proximity of the urethral orifice, there's often, many times people have got a vulvovaginitis land up with a urinary infection. Then, of course, very many times we all do a catheterization. I would say if you can prevent even one catheterization, please prevent it. Because I always tell them that one catheterization, if not properly done, it's a lifelong urinary infection for this particular woman. And of course, sexual intercourse. We even have conditions of honeymoon cystitis, etc., which tells us that sexual intercourse is actually something which predisposes to a urinary infection. The risk factors for UTI in the puerperium, not pregnancy, but the puerperium, is because the bladder sensitivity is often reduced due to the local trauma and the epidural analgesia. There's a discomfort of an episiotomy which contributes to diminution of bladder sensitivity. So many times the bladder is distended and she doesn't pee. Understand? There's many times there's even an overflow incontinence. And normal postpartum diuresis, which we often see around 40 to 72 hours postpartum, there is actually all the fluid gets absorbed from the extracellular space into the intravascular compartment, and the woman perceives a kind of diuresis. This is one of the reasons how many of the times we find the edema disappears in a few days' time. That is because of the God-given diuresis seen in 48 to 72 hours. And of course, the many times if we do catheterization in the pregnant woman in labor as well as postpartum. So all this contribute to the UTI. Now, urinary tract infection, this is the most common bacterial infection seen in pregnancy. It can be a cystitis involving the lower urinary tract, or it could be a pyelonephritis involving the upper urinary tract. The pathogens most commonly seen are the normal perineal flora. And E. coli is the most common organism, responsible for 90%. So much so you can treat every urinary infection, you can imagine it is due to E. coli and treat it. The other organisms are Klebsiella, Proteus, Enterobacter, and Pseudomonas. And many of these things are actually sensitive to the aminoglycosides like gentamicin, etc. It's good for you to remember this. The E. coli is there, and then you've got this gram-negative coverage of Klebsiella, Proteus, Enterobacter, and Pseudomonas. Now, Candida is the second commonest cause of nosocomial infection in pregnancy. How do you classify? We always classify UTI of pregnancy into three. First is the asymptomatic bacteriuria, second is acute cystitis, and third is acute pyelonephritis. Now, what is asymptomatic bacteriuria? It was first introduced by Dr. Kaz. The prevalence of ASB is about 1%, but the incidence can range from 2 to 10% during pregnancy. That means the patient has got, she's asymptomatic, but she's got a bacteriuria. And how do you define this? This is defined as the presence of persistent, actively multiplying bacteria within the urinary tract in women who have no symptoms suggestive of urine. She has no symptoms at all, but she's got enough of bacteria in her urine. It is diagnosed by the presence of more than 1 lakh bacteria of the same species, that's important, per ml in a clean void specimen. Let me tell you one thing, you will not diagnose this unless you do a urine culture. Routine screening at the first prenatal visit is recommended by many organizations like the ICOG, and E. coli is the organism responsible for most cases of ASB and urinary tract infection in pregnancy. As I told you all some time back, 90% it is due to E. coli. The smooth muscle relaxation and subsequent urethral dilatation and the vesico-urethral reflux in pregnancy can facilitate the ascent of this bacteria from the beam. If it is not treated, 40% of them will go in for acute cystitis and 25% of them will go in for acute pyelonephritis in pregnancy. ASB is associated with fetal growth restriction. So if not treated, the patients can go in for fetal growth restriction, FGR, preterm labor, premature rupture of membranes, maternal anemia, and preeclampsia. So these are all the commonest conditions which you can have when if you do not recognize an ASB and when you do not treat the asymptomatic bacteria. The current recommendations by the ACOG and the US Preventive Services Task Force suggest that all women pregnant should be screened at least once around the 16th week of pregnancy for ASB. So it's good to do a culture around ASB around the 16th week. Screening by culture and dipstick both is cost effective than no screening at all. The specimen should be cultured within 1 to 2 hours. Now, why that is important for us to know is supposing you're late in the evening, you're seeing your patients, and by the time the labs have already closed, remember, it is best given as a fresh specimen. Max, you can keep it for about 1 to 2 hours, but otherwise you should refrigerate it in the door of the refrigerator. And we say that more than 8, when you look at an ordinary specimen of urine for macroscopic features, we find more than 8 to 10 WBCs per high power field is evidence of urinary infection, or 10 to 50 WBCs per cubic millimeters is also significant. But supposing you see any leukocyte casts, etc., it normally suggests an acute kidney infection. And now you can also combine the WBC esterase and the nitrite testing, which is also an indirect way of testing for urinary infection. Now, how do you treat ASB? If ASB is detected, most obstetricians prefer to treat it. You can give amoxicillin, plain amoxicillin 500 milligrams 3 times. Or if you want, you can give ampicillin 250 milligrams QID, or a cephalosporin, either you can give 500 BD, or the BMI is more, you can give 750 BD. Or a nitrofurantoin, they are the usual drugs, 100 BD, and you can give it for 7 days in pregnancy. It is so easy to treat. You can catch them very early and treat them. A test of urine culture should be obtained 2 weeks after the treatment to make sure that the infection has been eradicated. So either you give ampicillin, amoxicillin, cephalosporins, or nitrofurantoin, excellent drug for E. coli. You can give it, and within 7 days, they are cured of the disease. But many women, 30%, will continue to have recurrent infection and may necessitate a longer therapy. So if the patient comes back to you with a recurrence, this may be due to relapse when the same organism is implicated or due to reinfection with a different organism. In cases of persistent bacteria or frequent recurrences, suppressive therapy for the rest of the pregnancy with low-dose antibiotics has been accepted. So you can give nitrofurantoin at bedtime, or you can give a cephalosporin 250 milligrams or even 500 milligrams at bedtime, can be given for the rest of pregnancy if this patient keeps coming back to you again and again. But please remember, many times nowadays, the culture gives trimethoprim as a sensitive drug, but this should be avoided in the first trimester as it is a folic acid antagonist and increases neural tube defects. So stick on to your ampicillin, amoxicillin, nitrofurantoin. Now from ASB, we go to cystitis. Now look at that bladder there. That is the bladder, and at the base of the bladder, you see the trigone. You've got the 2 ureteric orifices there, and then you've got the urethra opening into it. So that is a trigone. So cystitis is an infection of the lower urinary tract, and it characterized by dysuria, urgency, frequency. Usually there are no systemic findings. Please remember, a patient with urinary plain cystitis, normally, most of the times, they do not have systemic findings. If they have got systemic findings, you've got to think of that this has gone to a higher level. Urine analysis may reveal a pyuria, bacteriuria, and microscopic hematuria. That is why I said sometimes they may be losing a lot of blood even, and they may even become anemic, and we are not aware of it. Occasional hemorrhagic cystitis can result in gross hematuria also. If untreated, ascending pyelonephritis can result. Treatment is usually the same as for ASP. Isn't it very easy? Either you can give ampicillin, amoxicillin, cephalosporins, or nitrofurantoin for 7 days, as mentioned, and the urine should be cultured after 2 weeks to ensure the effectiveness of your treatment. So all what you need to do is, it is the same whether it be ASB or we have got cystitis, you can treat the same way. But now what is pyelonephritis? Pyelonephritis, you saw the picture of the kidney there, very familiar to most of you all. They've got the renal cortex on the outside and they've got the renal medulla on the inside. And you'll find that the renal pelvis opens out and you've got the calyces. Okay, and then you've got the nephrons, which is the basic functional unit of the kidney. Now, the incidence of pyelonephritis in pregnancy is 1 to 2%. So it's very easy for us to remember. Most of these urinary tract infections are about 1 to 2, but the lower urinary tract infections can come from 2 to 10%, but the pyelonephritis max about 2%. There is marked dilatation of the urinary tract towards the second trimester and the third trimester, with evidence of stasis and hydronephrosis due to the pressure of the gravid uterus. That also adds on. The dilatation is more on the right side due to the dextrorotation of the uterus, and progesterone is also responsible for the relaxant effect on the smooth muscle. And you'll find that the renal plasma flow increases greatly, so does the glomerular filtration rate. So acute infection of the renal parenchyma, I showed you the parenchyma there, and the renal pelvis. This is acute pyelonephritis, pyelo and nephritis, okay? So it's an acute inflammation of the renal parenchyma and the renal pelvis. Ascent of enteric bacteria from the bladder. Systemic and bladder inflammation from low-grade fever to very high-grade fever you can have. Dysregulated response in the elderly and the immunocompromised. And even 10% of them can also go in for a urosepsis and septicemia. Please remember that. We have had time and again patients, we have missed out on a pyelonephritis, and we have had patients not knowing the cause for the septicemia. It is more common in the primaries than in the multis. The past history of a urinary tract infection increases the chance by 50%, and the presence of an asymptomatic bacteria increases the chance by 25%. And if there's an abnormality in the renal tract, like duplication of the pelvis, etc., it is found in about 25% of the patients. You can get those who keep on getting repeated infections. The physiological dilatation of the ureters and the renal pelvis. You saw the renal pelvis and the ureters. They are due to the compression of the gravid uterus and the smooth muscle relaxation caused by progesterone. The low urethral peristalsis due to the high progesterone. So even apart from dilatation, even the peristalsis is poor. And the dextrorotation of the gravid uterus causing compression of the right ureter more than the left. Therefore, pyelonephritis is seen about 70 to 80% on the right side compared to 10 to 15%, but most often it is bilateral. The risk factors for UTI, we said low tract abnormalities, sickle cell anemia, diabetes, and the past history of UTI. The predisposing factors are dilatation of the ureters and renal pelvis and stasis of the urine in the bladder and ureters, the normal physiological changes seen in pregnancy. And here again, the commonest organism responsible is E. coli in 70% and Klebsiella, Staphylococcus aureus, etc., in the remaining. The clinical type, depending upon the mode of onset and the presenting features, the cases are grouped as acute or severe pyelonephritis, or it could be a chronic pyelonephritis. Acute pyelonephritis, the clinical features, the onset is acute and usually appears beyond 16 weeks of pregnancy. The involvement is bilateral, but if unilateral, it is more on the right side. The clinical features are mainly due to endotoxemia. That is why you get systemic effects. The chemical mediators of cytokines release IL-I, the TNF, and the endogenous pyrogens. They all contribute to the systemic effects which you normally see in a case of pyelonephritis, unlike you see in the lower urinary tract. The important features are acute aching pain over the loin, often radiating to the groin, and the costovertebral angle, that is the costovertebral angle, tenderness, there is urgency, frequency, dysuria, hematuria also. The patients have fever with chills and rigors, followed by hypothermia. Anorexia is there, nausea, that is what I told you, the systemic effects of vomiting, myalgias. Sometimes pyelonephritis may be complicated by septicemia and septic shock, causing hypotension. Sometimes even it causes an acute renal shutdown and a renal failure. So it is very important you think of pyelonephritis. And I will tell you, the important thing would be, apart from the chills and fevers and the past history of urinary tract infection, this pain over the loin, okay, the pain over the loin, and the many times they may not point to the loin, they might point to the flank. Remember, you will never get a flank pain with a cystitis. If the patient has got a flank pain or a costovertebral angle tenderness, then apart from the other urinary symptoms, think of pyelonephritis. Why should you think of pyelonephritis? I'll tell you why. Investigations, apart from the routine ones, the serum level of creatinine should be checked, electrolytes. See, formerly we were checking only the cultures for the lower urinary. But for the upper urinary tract infection, I told you they can even go in for severe sepsis, urosepsis, septicemia, etc. So you should check the electrolytes and the creatinine, and culture studies of the urine and blood should be done. And more than 10 colony forming units per ml in a midstream urine specimen tells you that it is indicated. Many times you can have a lot of differential diagnosis. It could be a pneumonia, it could be a right, because many times we see it on the right side, it could be a right lobar pneumonia. It could be a pneumonia also, you can mistake both a pneumonia and a pyelonephritis. It could be an acute appendicitis in pregnancy. It could be a biliary colic, because right-sided, many times when you see it only on one side, you may mistake. But I told you 70 to 80 times, if at all it occurs unilaterally, it occurs on the right side. So another differential diagnosis of biliary colic, acute cholecystitis, very important to remember. It could even be an abruptio placenta DD. It could be a patient presenting with preterm labor, chorioamnionitis, and red degeneration of the fibroid. So think of all these things as your DDs. The complications, there may be increased fetal loss due to abortion, preterm labor, intrauterine death caused by the hyperpyrexia. So always keep the temperature down. That's important. Even if you've got a problem, any type, whether it be this or a typhoid or whatever, keep the temperature down by giving the paracetamol 3 times. And then a chronic infection predisposes to low birth weight symptoms. Now, in a pyelonephritis, you will have to give them a supportive care like fluid resuscitation, antimicrobial therapy, adequate. See, earlier on, we said you only required the concentrations in the bladder. But here you require adequate concentration in the blood, the renal tissue, not just the urine. Okay. And the source control, find out the cause. And I can tell you at this point of time, many times we see a vulvovaginitis, the patients have got itchy. So if you do not treat that, they will keep getting a recurrent infection. So treat the urinary infection as well as your vulvovaginitis. And I will just tell you one more tip. It is good to give many of the probiotics in patients who have got the recurrent urinary infections. Okay, it helps. And as I told you all earlier, treat the vaginal infection. But here sometimes with the pyelonephritis, you may have to give them intravenous fluid for adequate hydration. Evaluate the hemogram, and I told you important 2 investigations apart from culture, do an electrolytes and the creat. Acetaminophen is given for the fever. Monitor the urine output and temperature and the blood pressure. IV, this is what I wanted to tell you. Why should you differentiate between a lower urinary tract and an upper urinary tract is because when you've got a pyelonephritis, you've got to initiate the antibiotic treatment as parenteral antibiotics. That is what I probably that's my take-home message to you all. And not only that, at least for the first 48 hours, you must give IV antibiotics, and you must give it for 2 weeks. If I have told you this, and if you all have understood this, I probably completed my lecture. IV antibiotics, cephalosporins, and aminoglycosides, because I told you they are the two commonest organisms which are susceptible to these antibiotics. You can give cefazolin or ceftriaxone for 48 hours till the culture report is available, and the patient remains stable and afebrile for 24 hours. Then you change over to oral, but remember to give that oral for about 10 to 14 days. If you don't give it, they will come back with a recurrence. Repeat the urine culture after 2 weeks, just as how you did for a repeated urea cyst. For one cystitis, you do not have to repeat it. But if your person keeps coming to you again and again, do the culture, and then after you have treated again, repeat the culture after 2 weeks. And if required, even at each trimester of pregnancy. Urine becomes sterile within a few hours of antimicrobial therapy. That is, IV antibiotics that you're given, the urine will become sterile. That is why take the culture before you're given the antibiotics. Patient may continue to have a flank pain. Many times it may not be a costovertebral pain, but it could be a flank pain that she's pointing to. If you see a patient with flank pain, why should she get it? Most often it is a pyelonephritis. Patient should continue to have a flank pain for several more days. They should be observed because, and that is one reason when you should observe them. The second reason is when there's a clinical deterioration, repeat a culture. And if you find that she's going down, remember to do a CT scan. It's important that you do a CT scan on these patients who do not respond to your antibiotics, because there could be an obstruction or there could even be an abscess. Very important. So patients not responding with your regular therapy, it is important that you do a CT. You can even do an MRI, it doesn't matter. Because MRI, we all know there's no radiation. So sonography, CT scan, radiography, whatever, if it is in the non-pregnant state, yes, you can do that, or you can do even an MRI for urinary tract obstruction. Antimicrobial suppressant therapy is continued till the end of pregnancy. You should continue if the patients have been getting repeated pyelonephritis. As I told you in the recurrent cystitis, continue to give them nitrofurantoin, because they can get recurrences in 30 to 40%. You can give them just a plain nitrofurantoin. Nitrofurantoin is a wonderful drug. Therapeutic thing, you give it as 100 BD, and if as a prophylaxis, you give it as 100 in the night. So ladies and gentlemen, with this, I conclude my small presentation on urinary tract infection in pregnancy. Thank you so much.
Dr. Shobha, Dr. Bharti. Thank you, Sarina ma'am. Dr. Shobha, you're there? Dr. Bharti? Dr. Shobha and Bharti are...
yeah, maybe they've got some net issues, I guess.
Yes, I think so. Thank you very much, Sarina ma'am. And that was absolutely wonderful. And now the audience will know why we called Dr. Sarina for this particular topic. And thank you very much, ma'am. It was absolutely quite clear and crisp. And we could have the lower tract and the upper tract as and discussed quite very well. And it's absolutely wonderful. And thank you having you with us, ma'am. And I'm sure we will have questions and we will take it at the end of the session, ma'am. We'll be happy if you could be logged in for
I'll do that.
Yes, ma'am. And we have the, let me share the slides, ma'am. Can you, madam, stop sharing. Now we have the next speaker, Dr. Ramani Devi from Trichurapalli. Dr. Ramani Devi has got a very long list of achievements and laurels and kudos and encomiums to her credit. And let me see whether I can do a précis writing of that. And Dr. Ramani is the Managing Director of the Ramakrishna Medical Center and Janani Fertility Center. And she's been an absolute gold medalist throughout her UG and PG periods. And then she's had so many prizes and awards to her credit. And she's been the Foxy Vice President very recently, and she's another person who's put Trichy onto the Foxy icon, and she's on the International Advisory Board member of Fertility Society of Bangladesh, and her work on endometriosis has been commendable during her tenure as chairperson of the committee. And Dr. Ramani Devi will speak to us today on surgical site infections in pregnancy, meaning which will speak to us only on episiotomy infection and cesarean wound infection. Over to you, Dr. Ramani, for your lecture, and happy to have you here.
Thank you, Dr. Palniappan. Let me start sharing my screen. Am I audible? Because
yes, ma'am. Yes, very well audible.
Yes, ma'am.
Okay, okay. First of all, let me thank Dr. Rishikesh Pai, the president of Foxy, and Dr. Lakshmi Srikante, the chair of ICOG, and Dr. Palniappan for making me a part of this wonderful masterclass series. So the topic given to me is surgical site infections in pregnancy. That means in puerperium, mostly the episiotomy site infection as well as the C-section scar infection. Now, to go about the definition of surgical site infection, it is an infection which occurs within 30 days of post-surgical procedure, either in the abdominal scar or in the episiotomy site, which will involve the skin, subcutaneous tissue, soft tissue, and even the deep tissue or even the organ or the space. Commonly used, if you get fever in the puerperal period, we should think of the first thing rightly pointed out by Dr. Sharina, urinary tract infection is the common infection. Next comes surgical site infection, respiratory infection, and breast inflammation and abscesses that has to be thought about. The incidence of surgical site infection is decreasing because we have an improvement of the hygienic condition, as well as all of us are in the habit of administering prophylactic antibiotics and following the standard infection control protocols. Although post-LSCS surgical site infections are not very serious, this may cause pain, discomfort, morbidity, stress, financial strain, and the extended stay in the hospital. So occasionally, patient can have deep-seated infections following post-LSCS. That usually occurs when the patients have a premature rupture of membranes for a longer period or handled outside cases. Episiotomy site infection can also lead to morbidity in the form of, again, pain, stress, and difficulty in mobilization. The women will find it even difficult to sit in a comfortable posture and feed the child. So the incidence is, it's among 7,235 LSCS that was done in Kuwait. They noted that the incidence was 1.7 to 2.95%. Worldwide, surgical site infection is found to be around 3 to 15%. It can contribute to 20% of the healthcare associated infections. The incidence in sub-Saharan African countries illustrated an average of 7.3%, slightly more than what is seen in the developed countries. The complex surgical site infections are declining from 0.84 to 0.15 as observed by Ferreira et al. The incidence is higher in underdeveloped countries as compared to developed countries. Like that is 7.3% versus 1.75 to 4.78%. A study that was performed in India, the incidence of SSI following gynecological surgeries were found to be greater than that of the obstetric surgeries. That is 10.3% in gynec surgeries versus 1.2 in obstetric procedures. So the superficial infection can amount to 2 to 7%. 2 to 16% can have endometritis, and the deep fasciitis, that is the necrotizing fasciitis, can happen in 0.18% of the cases. Now let us see who are all prone for this surgical site infection. First factor is increased maternal age, nulliparity, twin gestation, premature rupture of membranes, diabetes mellitus, and hypertension. Again, the patients with the pre-medical illnesses like cardiac disease, renal disease, liver disease, obesity is one important factor. Every 10% increase in the weight of the patient, the chances of infection is going to be double. Again, smoking is one universal risk factor for SSI and malnutrition, of course. The other risk factors are chronic immunosuppression, corticosteroid administration, repeated vaginal examination, presence of vaginal discharge, prolonged stay in the hospital prior to surgery that increases the iatrogenic infection, and greater than 1 hour of surgery doubles the risk of surgical site infection. So again, the inappropriate antibiotic prophylaxis increases the SSI by 5-fold. The depth of the subcutaneous plane and otherwise the obesity, higher the depth of the subcutaneous plane and the hematoma formation, the chances of SSI is going to be high, and prolonged post-surgical stay may increase the risk by 5% each day. Then hematoma formation due to cough and anticoagulants is seen in 2 to 5% of the patient. Nowadays, the patients who are undergoing C-section, most of them are higher than normal BMI, and the option of giving anticoagulants is being quite increased. So maybe that may be one reason why the patient can have hematoma and subsequently surgical site infection. Then it is known to be what are the main microbes that causes surgical site infection. It is mainly from the patient's own body rather than that of the outside. They can be transmitted from the OT or from the surgeon or the staff who are attending the patient. Most of the SSI are quite preventable. Necrotizing fasciitis is one of the dangerous ones that is characterized by the rapid progressive necrosis of the subcutaneous tissue and fascia, and it is quite rapid that it can expand deep into the tissues if it is left unseen within few hours. You have two types of necrotizing fasciitis. One is the type 1, which has got a polymicrobial etiology. Type 2 is caused by a single organism, mostly group A Streptococcus. Other organisms are Staph aureus, Klebsiella pneumonia, E. coli, Pseudomonas. And the infections, as I said, it could be nosocomial or iatrogenic if there is pre-admission into the hospital is for quite a longer time. Then mostly the postpartum endometritis is due to polymicrobial infection of the decidua. So now looking into the types of SSI, the infection, first one, minimal one is the superficial infection. That is, you can see it in the superficial area and in the subcutaneous region where it may present with some amount of discharge, either serous or purulent discharge. Then comes the deeper soft tissue infection where it involves the purulent discharge into the myofascial region. Again, into the organ space, there is combination of deep infection which extends beyond the myofascial layer into the peritoneal cavity. So these are all some of the types of infection. You can have a very superficial one, slightly a deeper one involving the beyond the subcutaneous fascia, and this is a case of a severe acute necrotizing fasciitis. So to classify what are all the types of surgical procedures? Surgical procedures can be clean, elective, non-emergency, non-traumatic, and there is no acute inflammation, no break in the sepsis, no respiratory or gastrointestinal or biliary or genitourinary tracts are entered. Then clean contaminated, that is urgent or emergency case where otherwise it is clean, elective opening of the respiratory, gastrointestinal, biliary, genitourinary tract with a minimal spillage, for example, in appendectomy, not encountering the infected urine or bile, and minor aseptic technique break. So then contaminated one is that is presenting with a non-purulent inflammation where there is gross spillage of tissue from materials from the GI tract or biliary or genitourinary tract, and there is a major breach in the aseptic technique, penetrating trauma more than 4 hours old, and chronic open wounds to be grafted are covered. Dirty wounds are that they have a purulent inflammation, for example, abscess, preoperative perforation of respiratory, GI, biliary, and genitourinary tract, and the penetrating trauma is quite an older one beyond 4 hours. So now we have some scores for this, that is asepsis score, where whenever there is a serious discharge, it is given a score of 0 to 5, erythema 0 to 5, purulent exudate 0 to 10, separation of the deeper tissue is 0 to 10, and isolation of bacteria is 10, and for stay over 14 days, score of 5 points. So the additional treatment, what you need is
You need a high cover of antibiotics if the points exceeds 10 and drainage of pus under local anesthesia or general anesthesia based upon the site where it is involved and the debridement of the wound under general anesthesia. Like for example, in necrotizing fasciitis, it gets a point of 10. Again, there is another score grading system to grade this SSI, that is Southampton wound grading system, that has been taken from Paley and Lau. Grade 0 is normal healing, and grade 1 is again divided into ABC based upon some bruising, minimal bruising, considerable bruising, and mild erythema. And grade 2, where you have the erythema plus other signs of inflammation like 2A, 2B, 2C, and 2D. That is where the erythema is at 1 point around the sutures or along the wound or around the wound. Then clear or hemoserous discharge that is seen at 1 point less than 2 centimeters along the wound, larger volume and prolonged greater than 3 days. 3 days we classify into 3A into 3D. Then frank pus can be at 1 point, it is 4A and 4B along the wound. Then deep or severe wound infection with or without tissue breakdown, hematoma that requires aspiration comes under grade 5. So now coming to the signs and symptoms of SSI, usually the time taken is from day 2 to 30 days post-operatively. Patient invariably presents with fever, local tenderness, warmth, redness, swelling on the 4th day after discharge, and then wound gaping, pus discharge. Severe intraperitoneal infection can present with systemic signs like high fever, tachycardia, dehydration, tachypnea, and all signs of sepsis, and the patient may have abdominal distension and pain. So invariably, these group of patients with the intraperitoneal infection, they require hospitalization. But whereas very minimal one involving only the skin subcutaneous plane, they can be treated as a by domiciliary method. So the necrotizing fasciitis usually present with a severe pain, woody in nature, in the subcutaneous, extending from subcutaneous tissue, and involves this. You can see the vesiculobullous lesions, and there is rapid progression. That is what I said. If you admit a patient with necrotizing fasciitis, what you need to do is you have to have a team of persons, that is a plastic surgeon and intensivist, everybody to assess them periodically and get everything done in a very rapid manner. Otherwise, the mortality is going to be sure. Then the postpartum endometritis is characterized by, again, spiking fever, abdominal tenderness, purulent vaginal discharge in 2 to 16% of the woman, and especially this happens when the surgery is done following a trial of labor and prolonged premature rupture of membranes. So now, how we are going to reduce the SSI? So first thing is prevention is better than cure. So how we are going to prevent it? First is preparation. Prepare the patient using a very good preoperative shower with soap and chlorhexidine. Shaving should not be done with razors. Instead, you can use scissors to cut short the hairy area. And then vaginal cleansing with povidone iodine solution is a must. Then theatre wear. Both the theatre wear for the patient as well as the staff should be in better. It's a clean theatre wear. Use of theatre gown is ideal, and again you have to cover the legs, mouth, and the head should be covered appropriately for the patient. And the theatre wear of the staff should have similarly a sterile pant, shirt, long covers, cap, mask, and once they are getting into this OT dress, their mobilization movement should be minimized, and they should avoid artificial nails, nail enamels, and jewelry should be avoided by the OT staff. Antibiotic prophylaxis. LSCS comes under a clean contaminated wound because it's being exposed to the vagina, which is a contaminated zone. Again, the preferable antibiotics is 3rd generation cephalosporin, which should be given intravenous prior to induction of anesthesia. Again, if you feel that the patient has got a higher chance of surgical site infection, then an addition of 500 milligram of azithromycin can reduce the SSI from 15% to 3%, and then endometritis from 8 to 2%, and postoperative febrile morbidity from 17 to 3%. Second dose can be repeated if you in situations where the patient has been in a ruptured membrane states for a longer time and a prolonged surgery, or the dose has to be calculated according to the weight. That is very essential because nowadays we get overweight patients only. So the dose calculation should be appropriate. Then what you should do to prevent complications, prevent sepsis in the intraoperative phase. The team should wash with a good antiseptic surgical scrub. Nails and hands should be clean. Alcoholic hands scrub should be used. And then operating team should wear sterile gowns and double gloves should be worn. And the preparation of the patient, skin preparation is just wash them with a good alcohol or a chlorhexidine or povidone iodine. In condition, if the patient is having allergic to povidone iodine, chlorhexidine may be another alternative. And you have to clearly wipe away all the alcohol. Suppose if you are going to use cautery to cut the skin, but invariably we do not cut the skin with a cautery. Instead, the deeper tissues can be cut with the cautery. So the intraoperative precautions are first and the foremost thing is maintains patient's hemostasis. That is very important. Avoid too much of hypothermia. Maintain oxygenation and perfusion of the patient. In diabetic patients, periodic blood glucose should be monitored. Just pre-induction sugar should be monitored, and every hour, probably if the patient is already on a insulin dependent state, or if she is a mild GDM or a mild altered glucose intolerance, maybe it can, the timing of glucose estimation can be prolonged. And then once we were telling that wound irrigation and intracavitary lavage may help the patient, but now again, it can increase the incidence of SSI and we have to restrict it. Then again, intraoperative precautions are generally, many of the surgeons are in the habit of exteriorizing the uterus, which has got certain advantages. Earlier, it was thought it will increase the incidence of SSI, but better we avoid it. And there is now, there is no evidence based thing to say that exteriorization increases the infection rate. Again, manual removal of placenta is associated with a high risk of endometritis. So allow the placenta to come out on its own just by a simple traction of the umbilical cord. Then application of antiseptics to the wound prior to closure is only under research setting, but practically I have been using it for quite some time and I find that it is quite useful. Again, when you come to the closure technique, better to, generally we are in the habit of using this Vicryl, and antimicrobial triclosan coated sutures may be of use in using uterine and facial wound, and skin closure should ideally be suturing rather than applying staples. Then the preferred method of suturing may be a simple interrupted suture, especially in patients who are at high risk of developing SSI. Because if there is chance of infection, then you can remove 1 or 2 sutures and drain the purulent or the pus discharge. Or if you are very thorough that if it is going to be a clean surgery, maybe subcutaneous skin closure can be attempted. Then again, based upon the thickness of the subcutaneous tissue, if it is greater than 2 centimeters, maybe subcutaneous closure is needed. And again, if the subcutaneous drain has to be kept if the plane is going to be more than 4 centimeters. So, currently subcutaneous tissue drain tube is not found to be of much use. But on the other hand, negative pressure wound therapy after LSCS is gaining popularity, especially in obese men. It reduces the excess fluid accumulation and protects the wound from irritation caused by reducing the frequency of dressing changes to only once in every 3 to 5 days. It has also been reported that negative pressure wound therapy is the only beneficial if the risk of surgical site infection is greater than 14%. That means in obese individuals or in high-risk patients with diabetes, etc., where the subcutaneous with thickness is going to be more, maybe we can try this. Then in the post-operative period, there should be used aseptic non-contact technique for changing or removing the surgical dressing, and preferably the surgical dressing should be changed beyond 48 to 72 hours, because most of us, we discharge the patient on the 3rd post-operative day after 72 hours. And regular bath can be given after that. An additional dose of antibiotics is needed only in certain cases where there is prolonged surgical time, obesity, or PROM. Otherwise, a single prophylactic dose of antibiotics is sufficient. Cephalosporins are the drug of choice. Then again, patient, generally they can have minimal amount of fever up to 100.4 degree Fahrenheit up to 48 hours. So anybody who is having a temperature of more than 100.4 beyond 48 hours, then we call them as postoperative febrile morbidity. And we have to think about two possibilities. One is surgical site infection. Second one is the breast engorgement, and urinary tract infection is another common cause. So we have been listening to Dr. Sherina's talk that as far as possible, try to avoid catheterization, because single catheterization is known to increase the urinary tract infection by 4%. Rarely thrombophlebitis can happen. So all these things, first look for open the dressing and see whether your wound is clean. Next is breast engorgement, whether it is there or not. Check for urine routine, and again, thrombophlebitis has to be considered. So that is, it is always safer to give thromboprophylaxis in patients who are obese. Again, if there is febrile morbidity beyond this period, patient has to be evaluated clinically for general signs of sepsis, inflammation, dehiscence or pus. And if there is pus or serous discharge, maybe we can send it for culture and sensitivity and continue the antibiotics with anti-inflammatory drugs. Then if, as I said, if you are putting individual sutures, that is interrupted sutures, 1 or 2 sutures can be opened and pus can be drained and culture sensitivity should be done. Again, plane of infection can be identified, whether it is superficial, deep or extension into the cavity, and management should be planned accordingly. See, basically, if you feel that there is a deeper infection, always an abdominal ultrasound in the postoperative period helps to know what is whether the patient has got some collection or by accidentally whether there has been any foreign body has been left behind. Then how you're going to manage. 98.3% of SSIs observed are superficial. We are fortunate, and they are very common. And these patients can be treated with a minimal amount of antibiotics and anti-inflammatory drugs with cleaning the infected site with a chlorhexidine, and they can be allowed to go for a daily bath, and then they do very well with the domiciliary treatment. Next is when they have a deep facial infection, the stitch has to be opened out, and with a clean water and betadine, with a normal saline and a betadine solution, you can go about for a forcible wash and dressing can be done. So the wound, if it can be allowed to heal by secondary intention, or sometimes if we feel it is quite healthy, then resuturing can be done. Again, appropriate antibiotics, anti-inflammatory should be given as per culture and sensitivity. So the third one is if it is going to be an intraperitoneal infection, when the patient presents with signs of systemic signs of infection, then they have to be evaluated. As I said, an ultrasound, and if needed, CT and MRI can help them. So if there is a presence of some intraperitoneal pelvic pus collection or surgical drainage should be done either by laparoscopy or laparotomy or by radiological guidance, and broad spectrum antibiotics and should be given both gram positive, negative coverage along with anaerobic coverage, and pus culture is a must. So then how do you going to manage the necrotizing fasciitis? In severe cases like this, the help of other specialty is needed. The extensive wound debridement, that is, the wound has to be explored every 24 to 36 hours. Sometimes if we have to open it every 12 hours and see whether it is progressing or whether it is getting controlled. And type 1 necrotizing fasciitis, where I said it is polymicrobial, we have to manage with vancomycin, piperacillin, tazobactam, metronidazole, and clindamycin. But type 2, where you are expecting only the streptococcus infection, we can manage with a combination of penicillin and clindamycin. Role of IVIG is not clear in this situation. Then comes the management of Clostridium infection. Thanks to the protocol of giving routine tetanus toxoid vaccines to the patient, we very hardly say this Clostridium infection nowadays. And if you find occasionally, then the combination of penicillin and clindamycin can be administered. Role of hyperbaric oxygen therapy is unclear. Supportive measures have to be done, and electrolyte acid balance has to be corrected, and we need a support of the intensivist. The mortality may go up to 25 to 50%. Then in postpartum endometritis, it is usually treated with clindamycin and gentamicin. Ampicillin is added for a better coverage of enterococcus. If there is fever persisting,
sorry, Ramani ma'am.
Yes, I'm going to complete. Okay. Yeah. So pelvic axis has to be thought about. Then rarely, if the wound is not healing, mycobacterial infection has to be thought about, and we have to do the culture and proceed more towards the diagnosis of mycobacterium, which you can treat it by anti-tuberculosis treatment. So these, and then coming to the episiotomy side, similarly, you have the 3 phases, that is the superficial, intermediate, and deeper one. And these wounds has to be treated with proper postnatal care, correct hygienic condition, and prophylactic antibiotics. And then if at all we need rehospitalization, and then ask the patient to educate them with a good perineal hygiene and clean with water, and then Kegel's exercise should be taught. So it is to conclude, it is usually superficial, deeper infections are rare, and post-operative prevention is essential. Asepsis should be followed at all levels. Prophylactic or therapeutic antibiotics and careful monitoring is needed. High-risk patients need they have to be monitored with caution. Early intervention is essential. So I thank the opportunity given, Palniappan. Sorry for exceeding my time by 2 minutes. Thank you.
Thank you. Thank you, Ramani Devi, madam, Dr. Bharti Maheshwari.
Yes.
Yeah, nice to meet you. And it is really very good, a comprehensive talk. And in fact, it is a need of our, because most of the time this topic is not covered. So I am so happy that you have covered this topic so efficiently, and the preventive aspect as well as all cares during operations and after operations, and their early detection, treatments, all things are highlighted. And so I think that audiences, they will definitely get advantage of this. So as time is running short, so perhaps now probably we move to the next topic. And our next speaker is none other than Madam TV Chitra Bhatt. And we all know that she is a passionate professor with academic and surgical skill. And she is a professor and unit head at the Tamil Nadu. And she is a very learned teacher, as well as have lots of their academic inputs, especially the papers presentations, as well as PG teachers, and created presentations to deliver lectures material in classroom. So very academic, Dr. TV Chitra madam. So she is going to have a very good topic, and that is also a need of our, and that is not very much commonly covered. So I would like to congratulate Dr. Palniappan that he has selected very important topics, and that is most important, that is the antibiotics, role of antibiotics, and how it should be used, how it should be judiciously used, and what are the advantages, disadvantages. So now, without doing any delay, to Dr. TV Chitra madam.
Thank you, ma'am. Can I share my slide? Okay.
Yeah, madam.
Okay. It's not moving. Slide is not moving. I just. Okay.
It is visible.
Full screen. Is it seen?
Yeah.
Yes,
it is
ma'am.
Put it on a slideshow. Put it on the slideshow mode, ma'am. Then
Yeah, it's on slideshow only.
Ma'am,
it's on the
slideshow option
presentation
is
mode.
there.
It's on the presentation mode.
Ma'am, upside header.
Yeah, 1 minute. Okay, PowerPoint. Okay.
Yes,
no,
ma'am.
it's okay.
Yes,
Now
ma'am. Now
Okay.
it's
Okay, fine. So at the outset, let me thank Foxy and ICOG for having given me this opportunity. And like how Dr. Bharti said, it is not a very straightforward topic. I'm sure why Dr. Palniappan gave me this topic, I do not know. But after having gone through the topic, I really found it was an eye-opener, and I found lots of very, very nice, interesting, and new things which were there. So I'll be quite brief. My topic is antibiotic use in pregnancy, which and what is not rational. Okay. So now, apart from iron and calcium that we normally use, the next common prescription that we do during pregnancy is antibiotics. Now, but we have to answer all these questions. Are antibiotics always safe? Are we using them correctly? Can it cause any adverse effects? What is the rational use of antibiotics in pregnancy? So over the next few minutes, I'm going to answer all these questions. Now, definitely all of us know that whenever we use antibiotics, like in conditions like PPRO, we know that it prolongs pregnancy and it reduces the neonatal infections. On the other hand, in spite of being so very useful in many conditions, we know that antibiotics are associated with a lot of fetal and maternal complications. It has been very new to me that there are so many fetal complications which can occur whenever we give antibiotics, and we're using antibiotics right and left. So I'm sure many of you all who is going to listen to this topic, please stay behind because a lot of interesting things are going to come up. Now, there's a lot of, in fact, it is one of the, it tops the public health service because on the top 10 issues, antibiotic use, there's going to be a lot of guidelines regarding antibiotic use, and is going to be a major priority in health services. Now, before we go on to the, we should know how these drugs are classified according to your FDA. Now, we know that we have A to D and then we have X. A is the safest. X is to be avoided. B and C, B is whenever there has been adequate trials in animals, but no improved trials in pregnant women. And C is when there are no trials either in animals or in pregnancy. D is there is definitely some sort of a fetal risk, but the benefits of giving the therapy exceeds the risk, and X is to be avoided. So whenever you come across a drug, it is very important before prescribing the drug to find out into which category the drug comes under, because there are so many drugs that is coming up these days. We do not know whether it is A group, B group, C group. B and C up to C we can we can use, but definitely not D. So let us see the common drugs which come under category A. All these folic acids, pyridoxine, all vitamins come under category A. So they could be given at any time. What about category B? Category B is penicillin, macrolides, combination of penicillin beta-lactam inhibitors, nitrofurantoin. That is very safe. When it comes to C and D, aminoglycosides, trimethoprim sulfonamide combinations, quinolones, all chloramphenicol, all this polymyxins, all this to be used with a lot of care. Category X is valproate, methotrexate, ribavirin, levonorgestrel, all that we're not going to use. Okay, so just take it from me that anytime when a new drug comes, you must see it under what category, and then only you have to give the drug. Now, whenever we give antibiotic, what is the aim of the therapy? We must see that we properly select the antibiotic, and it's important that we give the effective dose, because now, like many people were saying, it's very common that we see patients who are really obese or overweight. So it's important that you give them the correct dose, and there's so much of plasma dilution. So the same dose which acts during non-pregnancy may not be the same during pregnancy. So you have to adjust the dose according to her weight. And it's very important to see whether it is teratogenic. And any drug administration, it depends upon the gestation age and how you're going to give the drug, whether it's an intramuscular or intravenous drug, and what is the duration of the drug that you're going to give, and especially what is the amount of the drug which is going to get transferred. So you really have to look into the drug pharmacokinetics before you can administer all these drugs. Now, antibiotics are commonly used in these conditions like UTI, respiratory infection during COVID conditions, pyelonephritis, and chorea amnitis, PPRMs, group B streptococcal infection, bacterial endocarditis prophylaxis, puerperal sepsis, and labor, and during LSS. Most of it has been covered, so I will not touch upon many things, but whatever has not been touched, I will just tell you. UTI, madam has told in great detail. I also will tell you the same thing, but for UTI, you have to, the first drug of choice is always a Niftran, which is to be given in the important that you diagnose the case of pyelonephritis, and the drug that you can avoid during pyelonephritis is amikacin. Though amikacin, it is very useful in non-pregnancy because it belongs to category C drug. It is better that you don't give amikacin. Aminoglycosides, though it works wonderfully in pyelonephritis, it's better that you give a ceftriaxone. That is better. That will be the first drug of choice. PPRM, that's a very common condition that all of us come across. So in PPRM, whenever you give antibiotics, it is important that you give them because it can prevent infections, and it can prolong the latency period between delivery and your PPRM.
So the guideline, what is the guideline? Now we say it is PPRM when membrane is ruptured before the 37th week of pregnancy. Now when membrane is ruptured before the 37th week of pregnancy, the drug of choice should only be erythromycin, which should be given in the dose of 250 milligrams to be given QID for 10 days or until the person gets into delivery. However, the latest update says you can give azithromycin, because azithromycin, the advantage of azithromycin, that's also macrolide. The advantage of azithromycin is that it is a single day dosing. Here, erythromycin will give 4 days. So it is a single day dosing. And instead of giving multiple doses, you can just stop with one dose, once per day. And it improves the gastrointestinal tolerance. And it has a more cost effective. And it is almost similar or better efficacy. So whenever you have a PPRN, you can either give erythromycin or better still would be give azithromycin would be the drug of choice. Now, what do we do for group B streptococcal infection? All patients with PRM, that is membrane rupture after the 37th week of pregnancy, we don't routinely test for group B streptococcus. If your person has had a group B streptococcal infection diagnosed, we don't do it routinely, so we may not come across the case. But all patients with PRM after the 36th week of pregnancy, you should give them antibiotics to cover group B streptococcal infection. And the drug of choice would be either amoxicillin or penicillin. So the drug of choice is intravenous amoxicillin, which is given in a dose of 2 grams every 6th hourly, or you can give cefuroxime 1.5 milligrams every 6th hourly. Now, what about bacterial endocarditis prophylaxis? Now, a lot of the changes have happened, and bacterial endocarditis prophylaxis is very, very limited only for certain cases that we do, especially when a person has mechanical valve replacement, or if she's had a previous endocarditis in the previous pregnancy. So it is not necessary that you give IE prophylaxis for all patients with heart disease. In many places, they still continue to do it. Now they say you don't do it only when certain indications like valve replacement, or when she's had a previous endocarditis in the previous pregnancy. Only in such conditions you have to give them endocarditis. And what is the dose? You give a single dose of amoxicillin or ampicillin, only 2 grams, either orally or IV. It is not necessary that you repeat the dose. Earlier on, they were giving both ampicillin and garamycin. So now they've stopped it. It's only a single dose of ampi or amoxicillin. And if the patient is allergic to your penicillin, then you can give them clindamycin 600 milligrams orally. Now, alternatively, you can also give cefalexin. Now, cephalosporin should not be used whenever a person has anaphylaxis. So the dose is very simple for IE prophylaxis. Now, what about postpartum endometritis? Madam Ramani Madam has already talked to you all. So a simple regime, this is what WHO says. A simple regime is to give ampicillin and gentamicin. But you can also give clindamycin, and gentamicin can be used whenever you suspect a postpartum endometritis. Now, sepsis is very, very important. It's a life-threatening, whenever a person comes with sepsis and is shock, it's a life-threatening condition. So in such cases, they say it's is the third most important cause of maternal death apart from your hemorrhage, and then hypertensive disorders. That is the third most important cause of maternal death. So here, all these things, chorioamnitis, endometritis, septic abortions, wound infection, pyelonephritis, all this can give rise to sepsis. And the organisms is generally gram-negative, and a combination of both gram-positive and gram-negative organisms. So here is very, very important that you give them an appropriate antibiotics as early as possible. That is the most important thing. And with every hour delay, they say the mortality is increased by 7.6%. So whenever a person comes with sepsis, and then you identify that you think or you suspect that you might be in sepsis or septic shock, then you start with a broad spectrum carbamazepine group of drugs, or an extended penicillin group of drugs with like a piperacillin plus tazobactam should be given. Or you can also use a third generation cephalosporins. Now, the timing of the antibiotics is very important. Whenever you think there is shock, immediately after doing the basic resuscitation, the antibiotic should be started within the first hour. They say the golden hour. So the sepsis bundle says you have to start it within the first hour of diagnosis. And when you think that sepsis may be there, even then you have to start it within the first 3 days, first 3 hours. Now here you see that you're giving a very high antibiotic. You're starting off with the 3rd generation cephalosporins, or you're starting off with meropenem. So in such cases, you send for culture initially. And then once the culture report comes, it is very important that you do something known as de-escalation. What do we mean by this de-escalation? The de-escalation is you either stop the higher antibiotic that is given if the report comes as something else, or you can discontinue. Either you can stop it, or you can change over, you reduce it to a lower antibiotic. Because now it's very important that you do everything that the person survives. And once he goes into septic shock, you really have to give them a broad spectrum antibiotic, waiting the culture reports. If the culture report comes, then you switch over maybe to a lower antibiotic. And so it's not necessary that you continue the higher end antibiotic. It's important that you de-escalate the antibiotic. So this term de-escalation is a new terminology that all of us must know. You started on a higher antibiotic. It is important that once a culture report comes, you de-escalate, move it down to a lower antibiotic of whichever the culture report comes as. Now, what is the WHO guidelines regarding peripartum use of antibiotics? This is the latest, which is in 2021. So there might be some difference in opinion between the other speakers, but this is what is being said. Now, when all will they say antibiotics is recommended? Whenever you have a manual luminal placenta, when you have a 3rd degree or a 4th degree perineal tear, PPRM, when is it not recommended? We don't routinely give for all episiotomies. Uncomplicated vaginal birth, there is no need to give an episiotomy. We, in our institution, we follow the same thing. Every case of episiotomy, we don't give an antibiotic unless we have done something like a manual MROP, or when she's had 3rd degree or 4th degree. I'm sure many teaching institutions will follow the same thing. And when a person ruptures membrane nearing term, or is a rupture of membranes in the hospital, in such conditions also, there is no need to give the prophylactic antibiotic. Now, as far as cesarean section is being said, it's very important that you give them a single dose of 1st generation cephalosporins or penicillin. And they've said 1st generation or 2nd generation can be given, but however, 3rd generation cephalosporins is not very effective. It is 1st and 2nd is better than the 3rd generation. This is what the WHO recommendation is. And more important is the timing of giving the antibiotic. You have to give it at least 30 to 60 minutes before making the skin incision. Very often we see the antibiotic will be there. Initially they were saying you give antibiotic after the cord is clamped. But nowadays that has changed. You have to give antibiotic before the surgery, before 30 to 60 minutes. So as soon as the patient is, before wheeling in to the theatre when the patient is pre-op room, that is the time when you give them antibiotics. Because sometimes they say you give antibiotics, suppose the patient has some reaction, the anesthesia would not recognize. So that's why we were giving antibiotic later, but now it is very strictly said you must give antibiotics 30 to 60 minutes before the incision. That is when it's going to be effective. And it's only a single dose. You don't give a 2nd dose. The single dose is to be given. The 2nd dose is to be given only in certain conditions like obesity, prolonged labor, prolonged duration of surgery, or other manipulations, like Madam said. So otherwise, it's just a single dose. Now, so I've just briefly told you what is the guidelines. Now, what are the problems? Why is there so much? Why has this topic been given to me? What is the rational use of antibiotics? Is there something wrong when we give antibiotics? So when I looked up, one of the most important thing was there is so much of resistance which is developing. We've seen that when we've been using antibiotics for a long time, after some time you see, when you see the reports, is resistant to this drug, resistant to this. So the commonly used antibiotics, the bacteria is getting, I mean, because they've been using it for so long time, it is not susceptible to these antibiotics. So because of this resistant bacteria, so what happens is we have to move on, switch over to higher end antibiotics. So that is not very advisable, because after some time we will be left with no antibiotics. So because of this, unnecessary use of antibiotics should be restricted. And what is more important is, this is what was very new to me. Now, this antibiotics, we know that there's a lot of change in the microbial community. And what it happens is, it kills the beneficial host microbiome, and it leads to unhealthy microbial imbalances in the human gut. So whatever is healthy is being replaced by something which is unhealthy. And whenever, this is the most important thing. When you give antibiotics, this is the most important part. the healthy microbe of the individual is converted, it may not come back to the original pre-pregnancy level. They say a single course of antibiotic also, the microbe for you to come back to normalcy, it may not come back to normal. It might come back to maybe 85% or 90% of what was there initially, but it will never come back to normal. So even a single course of antibiotic, there is a change in the gut microbe and in the vaginal microbe of the pregnant individual. So, and what's more, there's a long-term effect on the newborn microbial colonization. This alteration in the microbial colonization in the pregnant individual will give rise to effect on the newborn microbial colonization. So what else can happen? The baby can have childhood obesity. There's a more chance of a risk of asthma in the individual. There's so many studies which have been come up. All this was new to me. And there's an increased risk of childhood epilepsy. So do we want our future generation to suffer from all those things by misuse of antibiotics? No, isn't it? And it's estimated that at least during 1 in 5 of all individuals are prescribed at least one antibiotic during their pregnancy. So a healthy microbe is very important for normal pregnancy. So maternal microbe is very important. I'm stressing this again in preparing the host for the post microbial symbiosis later on in life. Just imagine, just a single course of antibiotic is going to have so much effects on the child. And there are so many papers which are big papers in perinatal medicine, in newborn medicine, all which are saying use of antibiotics is going to affect the childhood microbe, and it's going to cause all these things: obesity, asthma, and epilepsy. Okay, this is what I said again. So coming back to what WHO defined as, what is rationale? What is the definition for rationale? Use of antibiotics. Whenever you use medicines appropriate to the condition, you must know this condition, is this medicine going to act or not? You must use medicines in the correct dose, and you must give it for the adequate time, not too less, not too more. And it should be the lowest cost. Just because a person can afford a higher end antibiotic, don't give. Only give what is necessary. It could be a less cost. So there is even if it is then, if it's effective, you only use that. You don't. There's no need to give her a higher end antibiotic. So in conclusion, use antibiotics only when necessary. To prevent infections, you always have to take aseptic precautions. Whenever you use aseptic precautions in labor, like we don't give antibiotics whenever you have a delivery in our hospital. So I'm sure everybody will be following the same thing. So whenever you use aseptic precaution, you're very sure that you're using it, there is no need to give antibiotics routinely. So we could restrict the number of antibiotics and the number of days that we give, and follow the guidelines and administer the said antibiotics for that particular indication. For all heart disease, don't give. Only if it's indicated, give. Similarly, for all PRMs, don't give. So whenever an antibiotic is necessary, you follow the guidelines and only give the set antibiotics. And always follow the antibiotics stewardship, which is 5 Ds. So what are the 5 Ds? You must make the correct diagnosis. You must give the correct antibiotic. Give it for the correct dose. Give it for the correct duration. And always de-escalate. So thank you very much for the patient hearing. And I must really thank Dr. Palaniappan for having made me gone through this and then learned so many important points. I thank Foxy and ICOG for this opportunity. Thank you so much.
Thank you, Chitra madam. And it was really excellent talk. In a timely, you have finished such a vague topic and so beautifully and covered all important aspects. And these aspects definitely has to be revised by all of us, because we know how, vaguely we use the antibiotics, and even our youngsters and residents, I have seen that they are in habits of using mainly the higher antibiotics without knowing the rationales. And also this was really eye-opener presentation. We should know, and we should always remain aware that there are lots of disadvantages if we use the antibiotic in the pregnancy, especially without indications or without knowing their actually dose and actually the things, because it it disturbs the microbiota, as you have already told. So this is a really very good lecture. I think that it has conveyed all things, and your last 5 Ds, that is very special thing we have to keep in mind. So thank you again, madam, and thank you organizers, Foxy, ICOG, Dr. Palaniappan, they have selected such an important topic. This is really, it is, very happy to see that it is really masterclass by ICOG. They're different from other webinars, different from other conferences, and it is really a basics, all what we must know, and it's very useful for all audiences. So again, thank you very much for opportunity.
Thank you, Dr. Bharti. It is my pleasure. There are a
I'll
couple of questions which will,
Some questions in the chat
Yeah,
box.
I'm just taking the questions. Dr. Deepa has asked a question. Fever is a defense mechanism. How will antipyretics help in pathology? Sarina, ma'am, you want to take that question, ma'am?
Yeah. Same. I agree that it is a manifestation or systemic manifestation whenever there is an infection. But most of the times when the fetal heart disappears is when there is a hyperpyrexia. You will have to keep the temperature down, otherwise you can have an IUD in your hands. It is not the problem behind it, but it is a fever that causes intrauterine death.
Thank you, ma'am. The next question is how to treat a patient with renal calculi complicating UTI. Dr. Ramani Devi, I'm sure she's there. No, that is also to Dr. Sarina. Yeah. Renal calculi complicating UTI.
Yeah. You don't have to do any invasive procedures then. You just treat what her problem is. If she presents with the ureteric colic or whatever, you treat the colic. And many times you'll find that they do not give rise to colics in pregnancy because of the large uterus. The colics, so you do not have to go in for any invasive procedures like lithotripsy or anything like that, unless you find a situation in which she's going for a urosepsis. Because of that, then of course that overtakes the.
There's one more question asked by the same Dr. Deepa. Amoxiclav and umbilical cord. I'm sure the last question is to Dr. Chitra.
Yeah, it can cause NEC, so it's better that you don't give. So that's known factor that when you give an amoxiclav and this combination, it can cause necrotizing enterocolitis. That has to be avoided.
And there's also some 5Ds in antibiotics.
Okay. So that's
she did tell again, Dr.
So I'll just to tell it again, you must know the correct, you must know the diagnosis of the condition, you must know the what drug that you're going to give, what is the dose, what is the duration, and de-escalation. That's a new terminology that we've done. De-escalate the drug. After giving the higher dose, you move on. If it's not respond to that, you move on to a lower dose of whatever the culture report comes as. Basic thing is you try to always in a practice, try to start with the lowest antibiotic which you think is going to be effective for that particular condition. So straight away jump to a higher antibiotic. If necessary, unless it's a person like in sepsis or septic shock, when you think it is, we do not know, when you don't want to err and lose the patient, all other conditions you try to use the one which your hospital guidelines would have had for this particular condition. You do this, so you go by those guidelines and give the lowest, and you give it for the lowest time which is possible, and only if it's absolutely necessary. That should be the take home for everybody. You don't give antibiotics. You only use it when it's absolutely necessary. Try to prevent. Prevention is always better rather than giving, because so many things. It was really, this topic was an eye opener to see that so many, one single course of antibiotic can cause so many things to the baby. It is really surprising. But there's so many papers which has come up all about antibiotics. So I think we should really look into antibiotic use, inappropriate antibiotic use. We should put an end to that.
If I can also add, I agree with Dr. Chitra. We also do not give any antibiotics for our normal delivery, for our episiotomies, and for uncomplicated instrumental delivery also we do not give. Simple, unless it's a very difficult one and with a lot of lacerations and a deep episiotomy, we do not give antibiotics. And also for when the patient comes with PROM, you just see if it is ruptured from outside is an indication. And in the hospital, more than 18 hours, up to 18 hours, you do not have to give antibiotics. If it is beyond 18 hours, yes, antibiotics.
Any other questions from the experts? I'm sure I saw Dr. Atul Munshi, Dr. Parag Binivale logging in the middle, and if there are questions and there are comments, they are most welcome to.
Somebody was asking, Palaniappan, so we should not use amoxiclav.
Yeah.
The same thing, yeah. It's
for preterm.
should not
For preterm, yes. That's what you mean, no, Chitra, for preterm PROM, isn't it? Yeah. But when they have delivered a term and in the postnatal period, amoxiclav has been used with safety. Dr. Palani, can I say something?
Yes, ma'am. Sure. Yes, Dr.
Yeah,
Shobha.
Yeah. So I'm sorry that I had to log out in between because of a family
Fine, that's
problem. I'm very sorry. But then the thing is, I agree so much with all the faculty who have come in favor of restricted antibiotic use, and we need to follow guidelines as far as antibiotic is concerned, and we also need to develop hospital-based protocols. I think it's very useful to look at whatever cases of sepsis we have, including SSI, and see that what exactly is kind of going around in our hospital premises, and then develop the protocol. And it should be a flexible one for change. And antibiotic stewardship is something we need to develop very strongly. And I agree totally with Dr. Sarina Madam and Chitra that no antibiotic for normality would be an episiotomy. Aseptic culture, I mean, the sanctity of asepsis should be preserved at all times.
That is important. From hand washing onwards to cleaning the perineum, cleaning the vagina, all those things, if you have adhered to, if you've got a clean delivery set, autoclaved aseptic sets available, separate for each delivery, then you don't require antibiotics.
Just one query I had to all the esteemed faculty today, that today, because of that NABH going around in all hospitals and standardization, the antiseptic solution of betadine is still being used in labor rooms, or has it been replaced by cetrimide solutions? I needed the faculty because there is some kind of dilemma in this field.
Dr. Shobha, if I can take the question, ours is an NABH accredited hospital. We still use betadine, and there are nothing against it. The cetrimide and other steriliums came into picture during the COVID. That's only for the hand rubbing, but not for washing. For washing, we still use two solutions. One is the povidone, and another one is the soap solution, which they have both of them. So whichever you're comfortable with, you can use. And I don't think there are any restrictions to use that as of today.
And also, when you're using, remember the strength is important. Chlorhexidine, when you use, it's 4%, and povidone is 10%. The scrub is 7.5% of povidone.
If there are no more questions, let me, of course, we'll have to ask Dr. Lakshmi to end the talk. But before that, let me thank the three speakers, Dr. Sarina Gilvas, Dr. Ramani Devi, and Dr. Chitra TV, who've done a fantastic job. And when I put the topics, I was wondering, whom am I going to call and what justice are they going to do? And now, audience, what justice the three speakers have done so wonderfully well. And we had a lot of questions cleared and a lot of myths and misconceptions, which has been absolutely clear now. And we also thank Dr. Shobha and Dr. Bharti Maheshwari, who's been here as chairperson, taking off time to come for this masterclass. And thank you very much. And it was lovely. And I wouldn't be ending the show if I I wouldn't be fulfilling the task if I don't thank the ICOG office, Mrs. Neelima, who really did help us by compiling the entire thing and sending the link. And Neelima, thank you very much. And it's an absolute pleasure doing this masterclass with Dr. Lakshmi Shrikande, Dr. Parag, and the entire Foxy and the ICOG office. And thank you very much. And over to you, Dr. Lakshmi Shrikande, for the final words of conclusion and wisdom.
Superb, fantastic deliberations, Professor Palaniappan, with lot of take-home messages. I must say, I myself learned a lot. So I'm sure all the attendees, they have benefited. And as you already said, this masterclass is able to remove many myths and misconceptions. So I'm so happy that our purpose is achieved by having this masterclass on the theme of infections in pregnancy. So happy learning. And next month we are coming with the topic you can announce. We are having masterclass in gynec topic. Palaniappan, you can give the details so that we can get these attendees can log in.
Yeah, the topic for next gynec will be endoscopy, the ray of hope. That is the topic for the next gynec session. And so we will have endoscopy as the theme, and then we will say what ray of hope or whether it is horror and scope. We have to see what it is. So we will see that next month, and the topic is getting ready. It is on the pipeline. We have made the topics. A couple of days it will be announced, and you can all be ready to log in on that day and awaiting for a movie release like that. Yes.
Thank you, Palaniappan. Thank you, Madhuri. You both are doing fantastic job as conveners of this ICOG Masterclass. Thank you.
Thank you.
Thank you very much.
Thank
And let me say that just like how Indigo announces, it's a 2-minute before time departure or before time arrival. We finished exactly 2 minutes before 7 o'clock. And thank you very much, ladies and gentlemen. Let me close the session. Thank you very much.
Thank you, Dr. Lakshmi Madam. Nice to see you, and all congratulations as a ICOG chairperson that you are really getting your goal. Thank you, and thank you, Dr. Palaniappan. Congratulations.
Thank you, Komal. You can stop recording.
Yes, ma'am.
Chalo.